Thank you so much, sir and ma'am. Thank you so much, and the felicitation program is over now. So let's begin the guest lecture, which is on the topic diabetic ketoacidosis and its management. So to chair this session, firstly, I'd like to invite Dr. Neelam Verma, ma'am, the professor and ex-HOD at PMCH, FIAP, FPAI, and WHO fellow, and also the recipient of Shishu Visheshagya Shiromani Award for the year 2023 in East Zone 23. Thank you so much, ma'am, for joining. And then I'd like to request to join our next Honorable Chairperson, Dr. Vijay Kumar Singh, the legendary pediatrician at Darbhanga and recipient of Lifetime Achievement Award at IPA 2023. And then I'd like to request Dr. Sajid Hussain, the eminent pediatrician at Darbhanga, and also the Joint Bihar Health Service in 1988. He was the part as the Joint Bihar Health Service in 1988, and also Joint Department of Pediatrician in 2023. So thank you so much, sir. So all the three chairpersons are now on board. So let's begin the guest lecture by inviting our honorable speaker, Dr. Anil Kumar. Dr. Anil Kumar is also here, so I would like to request the chairpersons to give all of us a brief introduction about Dr. Anil Kumar, who is our next speaker. Thank you.
Good afternoon, everybody. Dr. Anil Kumar is going to talk on diabetic ketoacidosis. He is an associate professor in Betia Medical College, Betia, and in the Department of Pediatrics, that's a government medical college. He is founder secretary, IAP, Vaishali District Branch, Hajipur, organizing secretary, Bihar PEDICON in the year 2015, has been secretary, IAP Bihar State branch during 18 and 19, CIAP Executive Board member in 2020, and East Zone IAP Pioneer Awardee in Shillong in the year 2019, has been Secretary NNF Bihar State Branch during 2001 and 2022 and has been Vice President IAP Bihar State. He's going to speak on diabetic ketoacidosis. We all know it's a grave situation, and in every day we face in our emergencies the case of diabetic ketoacidosis, and it needs hospital care and be treated by consultant pediatrician or able pediatrician, because there is a ketone increases and there is disbalance of fluid and electrolyte. I think he is going to throw light on this diabetic ketoacidosis. I'll request him to start the session and hand over the mic to Dr. Vijay Kumar. Okay, Dr. Anil Kumar, please start.
Thank you, respected ma'am, the chairperson of this session. Our respected chairperson, Dr. Vijay sir, and Dr. Kajin sir. At the outset, I am very thankful to the organizer of this PEDICON, who has given me the opportunity to speak on a very important topic, that is diabetic ketoacidosis. This is my alma mater, so I am very much excited to be here as a speaker on this, in this hall, because I have so many sweet memories in this hall. I am vividly recall all the sweet memories. Now, I know that this diabetic ketoacidosis is a very serious and rare condition. It is not so much common. When it comes across to in our clinic, it posing a very serious challenge to the treating pediatrician. So I am going to discuss about this in a short, because it is a very vast subject, but within the stipulated time, I will try my best to finish it. Although the TKA, diabetic ketoacidosis, is a serious acute complication of diabetes mellitus, it is more common in pediatric age group and adversely affect the quality of life during the childhood. Yes, the childhood is very much moribund, and the child who is suffering with this disease is very much serious. It is a state of metabolic decompensation that results from the deficiency of insulin, excessive production of the catabolic hormones such as catecholamines, cortisol, glucagon, growth hormone, and other stress factors like sepsis and trauma. The mortality rate is very high when there is no insulin. Launch it was the 100%, but because of the so much the treatment procedure that has come into the effect, the mortality is very low. It is just about more than 2%. Epidemiology, the diabetic ketoacidosis is the presenting manifestations of diabetes in 25 to 60% of a children with type 1 diabetes mellitus. It is more common in the type 1 diabetes mellitus as compared to the type 2 diabetes mellitus. In this type 2 diabetes mellitus, it is only 5 to 33%. More common in children younger than 5 years of age and those belonging to the family with the poor accessibility and medical care, because in this patient, the type 1 diabetes mellitus, there is a regular insulin therapy. If the patient has socioeconomic is very poor, then they will not access to the medical care, because they have to go through the continuous medical care. The risk of decay in the patient with known diabetes 1 diabetes mellitus is 1 to 10 per person per year. This is the diagrammatic presentation of insufficient or absent insulin. If the insulin is absent, then it will affect on the muscle cell, it will affect on the fat cell, and this will cause the increased glucagon production. This all will cause the formation of glucose, and through the glycogen chain, through the glycogenolysis, gluconeogenesis, and ketogenesis. And also, this increased glucagon will convert the fatty acid into the ketone. And this goes into blood, and there is an increased ketone and glucose in the bloodstream. Definition, how we will define the decay? If the hyperglycemia with blood glucose more than 200 milligram per dl, venous pH is less than 7.3, or bicarbonate level is less than 15 milliequivalent per liter. Ketonemia, that is, as you know, the ketone bodies are stone and steroid and beta hydroxybutyrate level. So where the beta hydroxybutyrate level is more important. The ketonemia is when the beta hydroxybutyrate level is more than 3 millimole per liter, or ketonuria. We can measure the blood ketonemia by the blood ketone measuring strips, but it is very much costly. So we can take the work by this ketonuria, and this ketonuria is also diagnosed by the deep sticks. If the urine ketones are more than or equal to 2 positive, then we will say that this is a case of ketonemia. Rarely have near normal blood glucose. In some cases, the glucose is normal, but there is a presence of acidosis and ketonemia. This is called euglycemic ketoacidosis. This is also an entity. Risk factors is very important. If the patient is newly diagnosed in cases the age is less than 2 years, delay in the diagnosis, lower socioeconomic status, so there will be a very chance of being the decay. If the diabetic patient is known, then if this is not taking regularly insulin, you have poor metabolic control, if he has a previous episode of decay, there are more risk factors of having this decay. GIT disorder with the persistent vomiting. If there is a patient having complaint of GIT disorder with persistent vomiting, this is one of the risk factors of this decay. Failure of insulin pump therapy. Insulin pump therapy is very important in the treatment of the decay. If it is failure, then there will be a chance of decay. Stressful situations like infections, trauma, and surgery. This is the classification. I know the bicarbonate is normal is 20 to 28 milliequivalent per liter. In mild cases, it is 16 to 20, moderate cases, 10 to 15, and severe is less than 10. pH is very important. pH is, if the normal, you don't know that normal is 7.35 to 7.45. If mild is in the case of mild, 7.25 to 7.35. In moderate, it is 7.15 to 7.25. And severe cases, the pH will be less than 7.15. But clinically, we know that in normal there is no change. While in mild cases of decay, the patient will be oriented, alert, but fatigued. In moderate cases, there will be a Kussmaul respiration, that is deep and rapid respiration, oriented but sleepy and arousable. But in the severe cases, the Kussmaul breathing is present, and the patient will be depressed respiration, sleepy to depressed sensorium, and or maybe in the comatose stage. Diagnosis. We should suspect the decay if a diabetic patient present with dehydration, severe dehydration, because of the both loss of intracellular and extracellular fluid. Acidotic breathing, Kussmaul breathing with a fruity smell. As you know that in the stone, the smell will be fruity one. Abdominal pain and distension. This is a very important cause of abdominal pain in the pediatric age group. That is the decay. Vomiting, persistent vomiting is very important. And altered mental status ranging from disorientation, obtundation, and coma. To diagnose decay, the following criteria must be fulfilled: hyperglycemia more than 200 to 300 milligram per dl, glycosuria, ketonemia, ketonuria, metabolic acidosis, that all has been said. Anion gap is very important. Anion gap is more than 10, we will suspect about the decay. If it is more than 35, then we will suspect that the decay is associated with the lactic acidosis also. This is usually accompanied with the severe dehydration and electrolyte imbalance because of the severe dehydration. Clinical and biochemical monitoring in diabetic ketoacidosis, we will monitor the vital signs, the heart rate, respiration rate, and blood pressure at hourly basis. Neurological observation, Glasgow Coma Scale is very important. If Glasgow Coma Scale is less than 8, then we will go for the mechanical ventilation. For warning sign and symptoms of cerebral edema, the fluid input and output, very important. Capillary blood glucose, we should measure the capillary blood glucose. Laboratory test with serum electrolytes, blood glucose, urea, calcium, magnesium, phosphorus, hematocrit, and blood gases. It's very important. It should be measured 2 hourly for the first 12 hours and then as required. Management step of the decay includes assessment of cause of or sequelae of decay. Because if the patient has previous history of diabetic ketoacidosis, we will assess the symptoms of the decay, sequelae, talk. We will take the short history and performing a scan examination. Quick diagnosis of decay at the earliest. Baseline investigation we will do, and treatment, monitoring, and avoiding complications. History, symptoms of hyperglycemia. If patient is having the old case of the type of diabetic mellitus, we will ask about the symptoms of the hyperglycemia. There will be any precipitating factors. Diet, what diet the patient is taking, what the bad diet or the insulin dose. Examination, look for the sign of dehydration. It's very important. We will calculate the fluid in the dehydration or the present weight, not on the past weight. Acidosis and electrolyte imbalance, including shock, hypotension, acidotic breathing, CNS status, etc. Look for sign of hidden infections. Fever and strongly suggest infection. Fever or hyperleukocytosis, leukocytic is very much more, then we can think about the infections. But in some cases, the hyperleukocytosis will be present in a spite of not having any fever. It may be due to the cytokines or the catecholamines hormones. And if possible, obtain the accurate weight before starting the treatment. Baseline investigation is very important. Plasma and urine level of the glucose and ketones. ABG, including sodium, estimation of sodium, potassium, calcium, magnesium, chloride, phosphate, bicarbonate, and arterial pH. Venous pH more important. There is some error in the arterial pH, so venous pH is more important. Complete blood count with the differential count. Further test are cultures. If we suspect of the fevers, then we will go for the investigation. We will go for the antibiotic treatment after any proper culture. Without culture, we should not give any antibiotics. Treatment, there are principles of the treatment. Careful replacement of the fluid deficit, very important by the fluid calculation. Correction of acidosis and hyperglycemia via insulin administration. Insulin administration is only the treatment of this decay other than the fluid correction. Collection of electrolyte imbalance. Because of the severe dehydration, there is a loss of fluid. There will be so much the electrolyte imbalance. Treatment of the underlying cause. Monitoring of the complications of the treatment. Manage decay in the PICU. If not available, it cannot be managed in the special care. But the decay, especially the severe decay, cannot be managed in the home or in the hospital. We will do the management in the PICU only. Main feature of ISPAD, that is International Society of Pediatrics, Adolescent Diabetes, management protocol for the diabetics, ketoacidosis 2018. Insulin is a main Insulin is a main therapy of this diabetic ketoacidosis. The insulin should be given in the 0.05 to 0.1 unit per kg per hour. But in the experience, we can say that only 0.05 unit per kg per hour is suffice. The fluid correction should be corrected over a period of 48 hours. Fluid insulin, start insulin 1 to 2 hours after the start of fluid. If we start insulin before the fluid, then there will be a chance of cerebral edema. Lowering of the insulin infusion, when the resolution of decay occurs, that is, if the pH is more than 7.30, bicarbonate is more than 15 millimole per liter, then we will lower the insulin infusion. Addition of the glucose to IV fluid, when the blood glucose has fallen below the 20 to 50 milligram per dl, or when there is a rapid fall of the glucose, then we will introduce the dextrose in the form of 5% dextrose with normal saline or 5% dextrose with ringer lactate. Type of fluid, we will only use to choose the fluid in between the 0.45 to 0.9% of saline, that is normal saline. We will not use more than this or not less than this. If you use, then there will be a chance of decrease or increase of the osmolality. In some cases, ringer lactase or phospholite can be used. In some condition, that is the condition is hypercoloric acidosis. In this case, this is the excessive amount of when we give the chloride, there is a chance of hypercoloric acidosis. In that cases, we will give the ringer lactate or plasma light. Calculation is very important. Fluid requirements, maintenance plus deficit minus fluid already given. As we know that where the patient is suffering with the mild decay, then we will presume that there is a fluid loss of 30 to 50. When the moderate decay, this is 50 to 70, and it's more than, if the severe decay, that is 70 to 100. According to that, we will calculate the fluid calculation. We will do the fluid calculation. In maintenance fluid requirements, as we know that the holiday Segar formula, that is the first 10 kg is the 100 ml per kg, second 10 kg is 50 ml per kg, and then after the 20 ml per kg. Deficit should be percentage dehydration into body weight. Is according to the mild, moderate, and severe. If the severe, then we will build the 100 ml per kg body weight, we will give the deficit. Hourly rate, 48 hours, we will manage we will calculate the fluid and we will manage the fluid correction for 36 to 48 hours. Anion gap, you can say that anion gap is the normal anion gap is more than 10, and when it is more than 35, that there is a chance of lactic acidosis. Physical laboratory diagnosis, we have already said. It is very important. This is the example for the fluid collection. For a baby weighing 20 kg with severe decay, assuming the 10% dehydration, we receive the 20 ml per kg. We will start the fluid collection. We will give the fluid in the first hours. Is according to the, if the patient is the severe decay, we will give the 20 mg per kg of normal saline. Maintenance fluid requirements. If the patient is 20 kg, that here we have calculated in the 36 hours. Maintenance of the fluid requirements for 36 hours is 1500 plus 750 ml is 2250 ml. A fluid deficit is 10%, so we will calculate that 100 into 20, that is 2000 ml. They will subtract that we have given in the first hour, we will subtract here, that is the 400 ml, and we will subtract 2250 plus 2000 minus 400, this is total is the 3850. We have been given the 36 hours, we have already given in the first hour. So we will calculate here by dividing this whole fluid by the 35, that is 110 ml per hour. So we will give the fluid in the 110 ml per hour. In the hypobolic shock, administer 0.9 saline ringer lactate or a plasma expander as a bolus dose 20 to 30 ml per kg body weight. This can be repeated if the state of shock persists. Dehydration without shock. The administration 0.9 saline 10 ml per kg per hour for an initial hour, and then restore balance, and then maintaining deficit we should do. When serum glucose is very important. When serum glucose, as we know that when we will start the insulin, the blood glucose will fall down 90 ml. So if the blood glucose will come up to 250 milligram per dl, then we will start the 5% dextrose, as I have already said. Insulin therapy is very important. We will give the insulin therapy in a low dose of insulin therapy in the 0.05 ml per kg. If serum glucose fall to 100, we will start at T5, and We will not give the bolus dose of the insulin, but that will cause the decrease, very rapidly decreasing of the osmolality, and there will be a chance of cerebral edema. Duration of insulin therapy will be continued insulin therapy till the pH will be more than 7.3, baric more than 15, and beta hydroxy will be less than 1 millimole per liter. Normal iron gap will be treated. Then we will stop the therapy or we will shift to the subcutaneous insulin. Correction of insulin therapy stop lipolysis. So when we give this insulin, the acidosis will automatically correct it. There is no need to give the bicarbonate. We will give the bicarbonate, it will adversely affect and it will cause the hypokalemia, hypophosphatemia, and correction of, we will give the potassium. When because there is so much loss of the potassium, there will cause of hypokalemia. So we will give the potassium in the 40 milliequivalent per liter. We will give the potassium. Monitoring, we will monitor serum glucose, must be measured hourly. This all already been said. Complication is very important. Cerebral edema, intracranial thrombosis of infarction, acute tubular necrosis, peripheral edema, pulmonary edema, deep vein thrombosis, hyperchloremic, metabolic acidosis, renal failure. These are all the complications. We will treat with reduce the IV fluid, raise fluid fed, IV mannitol. We will give the hypertonic solution, 3% normal saline for 5 to 10 ml per kg, but waited 30 to 60 minutes. Dexamethasone is not recommended. So this is a take-home, you can say that this is a take-home message. The diabetic education is very important. We will give education to the parents for the continuous treatment of this type of diabetic mellitus. Blood glucose monitoring is very important. Sick day management is very important. Home monitoring of the ketone. We will use the home monitoring of ketone or beta hydroxy by the using of the blood ketone strips, supplemented short-acting insulin regimen. We will give the short-acting insulin regimen or easily digestible liquid diets we will give, reducing rather than eliminating insulin when patients are not eating. Guidelines for when patients should seek medical attention, case monitoring of the high-risk patient, and a special education for patient or pump management. These are very important. Thank you, sir.
Thank you, Dr. Anil, for giving such a nice and in detail everything has been discussed. Thank you very much. I'll hand over the mic to Dr. Vijay Kumar.
I must congratulate you for making an erudite exposition of a very complicated subject in a very short possible time. Thank you.
Thanks, Dr. Anil, for nice presentation of important topic. Thank you.
Thank you so much, sir. And I'd like to be requesting the chairpersons and the speaker to move to the rear side of the hall, of the auditorium, to collect their respected mementos. Thank you so much to all the chairpersons for chairing this session. Thank you so much, speaker, for once again enriching us with the shower of knowledge. Thank you so much, everyone, for your kind and patient listening. And let's now move to the next segment of this event. And we are going to discuss our next topic, which is ideal age for interventions in pediatric urological problems. So this is going to be our next topic. And I'd like to call upon the stage all the chairpersons one by one. Firstly, I'd like to invite Dr. Satendra Shekhar, who is an eminent pediatrician of Dehri on Son and also the president-elect for Darbhanga for the year 2025. So, respected Dr. Satendra is requested to come. Thank you so much. And next chairperson is invited, Dr. Muhammad Azad Kareem Bakhtiar, the consultant at Lilly Healthcare and Paras Global Darbhanga. And then our third chairperson, Dr. Ajay Kumar, the MCH Pediatric Surgery as SIDMS Medical College Jaipur. Now I request the chairpersons to please have a seat. And now it is the time to invite the keynote speaker for the topic, Ideal Age for Interventions in Pediatric Urological Problems, Dr. Sandeep Kumar Sinha. Dr. Sandeep Kumar Sinha has come on the stage. So let's quickly move to our next topic. And before anything, I'd like to request our Honorable Board of Chairpersons, any one of them, to please give us a brief introduction about Dr. Saab. Thank you.
Hello, good morning to all. The topic of this session is ideal age of interventions in pediatric urological problems. And the speaker is Dr. Professor Sandeep Kumar Sinha. He is Director, Pediatric Surgery and Pediatric Urology, affiliated to Medanta, the Medicity, Gurugram, Haryana. He is Commonwealth Medical Fellow UK and Gold Medalist, MS General Surgery, University of Delhi. Earlier Professor Pediatric Surgery at Maulana Azad Medical College, Delhi. Helped establish the Department of Pediatric Surgery at Madhukar Rainbow Children Hospital, Delhi, and now working in Medanta Medicity, Gurugram. He is an accomplished pediatric surgeon with over 15 years of experience. He specializes in pediatric urology, pediatric minimally invasive surgery, pediatric GI surgery, and general pediatric surgery. He has written a book titled Surgical Disease of Children, a book devoted to needs of pediatricians and allied specialists. He has more than 50 publications in national and international high-impact journals. Start, Dr. Sandeep Kumar.
So thank you, sir, for the kind introduction. But what the introduction has not told us is that first 12 years, that is class 1 to class 12th, I was in Kendriya Vidyalaya number 1 Gaya, and Dr. Madhu is here. Dr. Madhu, I was one of the students of various, sir. You met in Gaya. So for the class 1 to class 12th, I was in his school only. And now from moving out, definitely when I come to Patna, I come to Patna Medanta Hospital for the monthly OPD. Definitely like to meet you and sir also, and Dr. Hans sir also. So, no, so I just noticed a few last month only. Now coming about the topic which I'd like to discuss with all of you, the ideal age of intervention in the pediatric urological problem. It is important for us as a pediatric surgeon and you as a pediatrician to work in the coordination with each other, and so that appropriate time, appropriate treatment can be provided to the children. Otherwise, the children will suffer and these will have lifelong implications. The good thing about the pediatric surgical problems is that if you correct that at the appropriate time, the child will not have any problem for the rest of your life in comparison to the neurological problems, the genetic problems you as a pediatrician are commonly dealing with. So, if we have a pediatric surgeon university, Dr. Azad is there. He was earlier in one of the students in IGMS Medical College when I was in contact with him, and now he has come back to Darbhanga full time and giving full time to this city. If you support him, definitely the quality of care will improve for the children, and definitely with the help, the quality of pediatric services will also improve in this part of the world, which obviously in spite of being a big medical college on here and the AIMS is also coming here, the pediatric surgical services, he's the first pediatric surgeon to join in this part of the world. Nowadays, what is happening is that because of the development in obs and gynae, the fetal medicine part, everywhere the fetal medicine people are doing ultrasound, and with their obviously experience, more and more of these are being detected in the antenatal scan, and this is true in this part of the world also, because again, lots of deliveries are happening in DMCH and the peripheral part, but fetal medicine part is lacking, but slowly and progressively improving. If they're diagnosed in the antenatal period, definitely the parents are in loss, and you as a pediatrician also sometimes at loss, because we do not know when to intervene and what is the ideal age of intervention. This is the first question commonly asked by the parents from the pediatrician. There has to be certain scientific rationale behind these decisions. And what I will do is that in the next 10 to 15 minutes, I will try to discuss with you what are the concepts based upon which we as a surgeon decide about the appropriate age of treatment. As you always say, there's a difference between memorizing and understanding. The page we can memorize, but what I want is that we should try to understand, because health asset is more of a social science rather than the medical science. So there cannot be one criteria all over the world. Depending on the circumstances we deal, we have to decide about the appropriate age of management. And then last but not the least, things change. When we were undergraduate, when we were teaching in the Maulana Medical College in year 2008, this is the classical Benilab textbook of surgery. This was written, the ideal age of orchidopexy is in the range of 2 years. Now, what has happened in the last 10 years, if you see the recent edition 2018, and now the new 2023 edition has also come, the age has gone down from 2 years to 6 to 12 months of age. And in those, if you see the Indian system of teaching in the medical college, during the undergraduate days, we read this book, and then we give our PG entrance examination, and then we branch to different branches, and that's where the pediatricians are not taught about the surgical things. And they always remember कि मैंने तो अपनी UG में पढ़ा था, the age of orchidopexy is 2 years. They always tell your parents, but we do not know that the recent edition has changed. And what now has changed majorly is that the patient has also got power. With the advent of internet, with the advent of Google, almost all the patients, even rickshawala, if their child, they are intelligent, are searching of this, and they will start searching. आपने बता दिया 2 साल, new pediatrician आया town में, उसने बता दिया 6 महीने, and now they start searching the internet, and they will say that the ideal age is between 6 to 12 months of age. Now the basic difference between your understanding and the patient understanding will be that you will be deciding based upon the social circumstances also. You will join the dot and come to the conclusion, but the patient will read this and he is always confused. And that's why when the call came to me for some discussion on certain topic to the pediatrician, being odd met out, I decided that this is an important topic with which we must be familiar with. We must discuss with you what should be the ideal age for these interventions so that the appropriate treatment can be taken. Definitely, I wanted to come to this part of the world. The only time I came was around 25 years back when one of my MBBS friend was married to this part of the world. And then I still remember the amount of food which we have given to us in the Mithila, the classical Mithila marriage, one of those I have attended approximately 25 years old back now. So there are lots of conditions which can be discussed with all of you. But again, common conditions we would like to discuss with you, and this again classical Benilab textbook of surgery chart. The common condition which I would like to discuss with you are undescended testis, hernia, hydrocele. Apart from that, if you see the incidence, hypospadias and the PUJ obstruction are the commonest congenital anomaly with which you as a pediatrician are likely to come across. So definitely these are the only 4 to 5 things I would like to discuss. There are a plethora of diagnoses which can be, but obviously it is difficult to remember in these meetings each and everything. So even 2 to 3 things we can memorize or understand or take care in the patient. Obviously the aim of this lecture will be fulfilled. Now I'm giving you 3 clinical scenarios, which is very, very common in the busy clinical practice. As Dr. Shah was telling, 200 patients are being seen by the pediatrician in the OPD in a day. Obviously, brain has certain limitations also, and they are likely to miss certain things. But what is common is that if you go to take delivery in the obstetrician clinic, the scene number 1 is quite common. Maybe with the advent of NICU here, I have seen many of the souvenir, lots of NICU being born here. So newborn delivered, birth weight 2.5 kg, routine examination, only 1 testis palpable, but all other things were normal, very common. You compare this with the other scenario, which is more prevalent, because it was not diagnosed in the neonatal period, the guys have taken delivery, the pediatrician, trained pediatrician was not there, the grandmother noticing the same scenario at 3 years of age, and last but not the least, this is becoming more and more commoner, 10-year-old male child, बचपन से आप उसको पीडियाट्रिशियन में फॉलो कर रहे हो, ग्रोथ न्यूट्रिशन एवरीथिंग आपने किया है, सडनली उसके पेरेंट्स आ गए, डॉक्टर साहब both the testes are not there in the scrotum of this child, and you are always worried कि क्या गलती होगी, हमने मिस तो नहीं किया है, and that's where the three common problems felt in the OPD. Now, I want you to take a split-second decision in all of this. Do not try to go into this. The first and foremost question which comes to our mind is, what next investigation, and prone to write ultrasound. Obviously, the parents will ask if Dr. surgery can need hogi ki nahi hogi. This will answer definitely. If that is not there and the test is present, it has to be brought to the anatomical side so that it can function properly. And when do you plan for surgical intervention? Obviously, most of the time, ultrasound is written. But the point is that the ultrasound is the least needed investigation in this scenario because it is always a clinical diagnosis. Sent to a surgeon, Asad is here. If you do a good clinical examination, you do not need ultrasound because we as a surgeon differentiate these into whether it is palpable or impalpable testes, and depending upon that, we will monitor the child or manage the child. But obviously, still I see ultrasound being the first investigation. Big clinician thinks so patient testes nahi ultrasound kara lo, and that's where many times the problem is. So I approach the child, do the clinical examination, decide palpable and impalpable, and manage dependent upon the clinical examination finding. Now coming first to the last scenario which I discussed with you, this is the scenario which is known as retractile testis. So what is happening here is that because of the cremasteric reflux, more so in this cold environment, the testes are being pulled back into the upper part of the inguinal canal, and we get a radiological investigation done, which is the common is the ultrasound. You all know ultrasound is a static picture of a dynamic process. During the time of the ultrasound, the radiologist will say that the testis in the scrotum is not in the scrotum but in the inguinal canal, but it is not the diagnosis. The diagnosis still here is normal testis. Only regular follow-up is required for this clinical scenario. Very important for us to diagnose this condition, more so if you are following the child for long period. And now coming to the guidelines, scene 1, a standard orchidopexy between 6 to 12 months of age, whether open or laparoscopic, the surgeon will decide. Second scenario, missed one, definitely as soon as possible, get the orchidopexy done. And last one's third scenario, obviously observation required. Now you need to understand why the age of surgical intervention has gone down from 2 years to 6 months. And the very simple thing is that we all know nowadays, based upon the electron microscopic studies, that the testicular damage occurs after 1 year of age. So if we do not bring it down to the normal scrotal position where the temperature is slightly on the lower side from the rest of the body, testes will be damaged for rest of the life. But the point is that there's certain social dynamics to this decision also. If the surgical facilities are not available, if the anesthetists are not available, if the pediatrician is not trained to manage the 6-month-old child, definitely you can postpone it. Safety is #1 criteria, as I said in one of the slides. Do no harm. So obviously, safe surgery is important, but try to develop the resources in the area so that appropriate time, 6 months surgery, at the age of 6 months, surgical intervention can be done. Now coming to the second scenario, very common scenario, hydrocele hernia. And this hernia, again, this video was sent from this part of the world only to me by one of the mother. कि डॉक्टर साहब ये मेरे बच्चे का delivery हुआ था, and now out of the ICU, and now this is swelling which suddenly appeared. The parents are worried कि ये क्या हो गया. He was there in the ICU for so long, and suddenly this type of changes occurred. So, NICU graduate developing hernia. What next? An investigation. The second scenario the reducible swelling in the groin area. Obviously, if it is there, the diagnosis is hernia. And last but not the least, 9-month-old child, left scrotal swelling. You do a clinical examination, and that is a transamulet swelling. These are three common scenarios which is there. And again, same question, any investigation, same answer, no. Always the diagnosis is clinical, roll of ultrasound. So from your busy schedule, give some time to these children, do a good clinical examination for 1 to 2 minutes, and definitely have a torch. Hydrocele can be diagnosed easily without any problem. It is important for us to diagnose, because if you have diagnosed it correctly, you can prevent the child from going to the surgeon for the first 2 years of life. Obviously, observation is a treatment required for a child from 9 months with hernia, hydrocele. The concept behind all of this, for hernia, the treatment is herniatomy at discharge. Obviously, elective herniatomy will be needed in a 4-year-old child with hernia. Now, what is the concept behind this decision? 1 or 2 minutes I would like to discuss with you. We all know from a classical belly love textbook of this chart, always asked in the examination, everywhere in RIMS also, in DMCs and in MAMC also. You have to understand this important chart, that the hernia, if the opening is small and only the peritoneal fluid can come, we label it as hydrocele. And we all know, as the content cannot come, there cannot be any risk of complication. There is chances of spontaneous closure because of the testicular descent consent patent processes vaginalis. So there is a spontaneous resolution of the problem, no complication. We will like to wait in a child for congenital hydrocele. On the other hand, if you see the hernia, the maximum complication in the hernia occurs within the first year of life, more so if the child is premature in the NICU, and that's why we want to operate it. And when the complication will occur, no one knows. It can happen today, the child has shown to you, and the night it can happen, may not happen for the rest 1 year also. So this is unpredictable situation, and that's why we do not want to take any chance in this clinical scenario. No risk of complication is there with the congenital hydrocele. And then few other questions are always asked for the parents. मेरे बच्चे का एग्जाम होने वाला 1 महीने हो सकता है, आराम से वेट कर सकते हो. Again, I have told you, before school going age, less than 1 year, more chances of complication, जल्दी करना होता है. स्कूल जाने वाले बच्चों को कर सकते हो. जब 4 साल में कुछ नहीं हुआ तो 1-2 महीने में कुछ ओपन नहीं वाला. Open surgery, laparoscopic, choice of the surgeon, pediatric and the adult hernia are not same. Many of the patient will Google और suddenly उनको mesh लगाने etc. की चीजें आ जाती हैं, which is not required. Obviously, hardly same side, opposite side hernia can come. Tennis classes हमारे सेंटर में, जब मैं गुड़गांव में काम करता हूँ, साउथ दिल्ली में, obviously there is a very common concern, and most of the schools are now also having Western concept कि बच्चे को horse riding, tennis etc. हमारे बच्चे भी करवाते हैं. So obviously we like to wait for 6 weeks, and insurance coverage, very basic problem in Gurgaon, not in this part maybe, because most of these are now funded by the parents who are working in the corporate setup with certain things. Last one, the antenatal hydronephrosis, and very, very brave, obviously, because of lack of time, not going to detail. I wanted to focus on these 3 situations only. Hernia, hydrocele, and undescended testis, very common scenario. But nowadays, we all as a pediatrician are getting around 20 pages of WhatsApp report कि बच्चा deliver हुआ है और suddenly उसके 3 antenatal scan थे, सबने face किया होगा. और antenatal scans की problem है क्या? They charge 5,000 rupees or 4,000 rupees for the antenatal scan, तो उनको कुछ report देनी होती है, and most of those reports are 8 page, 10 page, 15 pages report, बहुत सारे photograph देते हैं. Now we as a surgeon, you as a pediatrician searching, इतना time नहीं होता कि कहाँ से हम important चीज़ देखें, and that's where many times the antenatal scans, in spite of getting an antenatal scan, the obstruction, the hydronephrosis are been mixed. Now, these are the common questions: when to intervene, how to intervene, is the child small for intervention, and what is the prognosis. इसमें बहुत ज़्यादा concept नहीं है, बहुत ही simple concept होते हैं कि unilateral upper obstructions are never urgent, concept number 1, because the other kidney is normal and the chances of damage during the first 1 or 2 months of life is not that much. On the other hand, if the obstruction is below the bladder, definitely it is an urgent scenario, because it will damage both the kidney, and I can assure you that if one can pass a catheter in the newborn with bilateral obstruction, the kidney will function for 40, 50, 60 years. On the other extreme, if you have not passed catheter for a month or 2, the kidney will get damaged in 10, 20 years. So much difference in the life of the child, simple catheterization in the newborn period can make. Obviously, after that, depending on the scenario, we get an ultrasound to day 3 and 7 for life, unilateral obstruction, discharge after counseling, and there are lots of antenatal scan. I'm not going to detail of these. We get in diuretic radiography. Nowadays, most of these we are going to laparoscopic surgery or robotic surgery. We do not want to give any scar to the children. We do not want to them to remember that bachpan mein kuch bimari thi, and that's where the scarless surgery has come in a big way. Early intervention are definitely in the literature also beneficial in compared to the delayed intervention in this scenario. So few of the surgery and few of the laparoscopic surgery we have done in last few years for our children. Bilateral obstruction, definitely catheterize in NICU and do early surgery. Whether possible or not, catheterization will help Dr. Asad this year. He must have bought these instruments. What has happened that because of the high definition camera systems and all of these monitors which you are seeing here, our quality of surgery, our surgical intervention, our visibility has also increased, and you cannot make a mistake. So I will recommend him, if you have not bought, buy these instruments, 3 lakhs, small pediatric cystoscope. This will help you in a long way in taking care of these congenital problems. 8.5 French scope is always available in the range of 2.5 to 3 lakhs. And you cannot make a mistake because of the quality of the optics which has improved in the last few years. Obviously, surgeon is important, but more important, the gadget with which he is working in the different scenario. And these are few of the results which we have done in the last few years with almost normal kidneys, almost normal. If you remember, Cameron Green is the Australian cricketer who is same case of posterior atrial valve. Now he is in CKD stage 2 because properly managed and is still playing for his country and going good result. So point is that if you have done the intervention at appropriate time, these children will not have any problem. And last but not the least, and very brief, hypospadias, I call it dada dadi nana nani disease. हमेशा बच्चे को लेकर आते हैं कि it is not possible for us to retract the prepuce in my child. So what to do in these clinical scenarios? Surgery की need है, non-surgical intervention की need है कि नहीं? When to ask for circumcision and what is the prepuceal retraction? Now, this concept we must understand and must remember because this will prevent many of the surgery which is happening in many parts of the world. And that concept is that the development of prepuceal retraction is a very slow and gradual and variable event that occurs between birth and the completion of puberty. Non-retractile prepuceal skin is there in the 50% of the child in the first year of life, which decreases to 10%, and by puberty only 1% of the children will have non-retractile prepuce. This fact is not known to most of the eyes. What they will do is that in the newborn period, they will try to retract the prepuce, leading to these microhemorrhages, and these small hemorrhages, they will heal by fibrosis. They come in contact with urine, and because of this, 1 year down the line, if you try to retract it, it will not be possible for us to retract it because it has healed by fibrosis, and this child will need surgical intervention. Otherwise, simple steroid cream, betamethasone, or whatever you want to use in the low dose is very, very effective in more than 90% of these children. Very common problem in the OPD. We do not want to offer circumcision or prepuceplasty to these children because every surgery has certain risk of complication. So circumcision or prepuceplasty is only recommended for few scenarios in which the child is having recurrent episodes of prostatitis infection or ballooning of the foreskin sometimes also. And last but not the least, hypospadias, when to intervene, how to intervene. Simple formula. Again, the age of treatment has decreased to less than 1 year of age before the child has started walking because of these scenario, good reasons of penile growth, decreased anesthesia. I'm not going to enumerate all of these. The point is that everything has become calmed down to earlier age because healing is better in children. If the cord is, the kink in the pain is there, if you correct it early, chances are that the child will have lifelong, no problem related to in the latter part of the life, and that's how less than 1 year of age, just try to remember, is the age at which the surgical intervention is, and we'll do lots of these intervention in our surgical setup. Hypospadias is very common surgery, which we as a pediatrician, and for us, passage of urine from a tip of urine is very heartening thing to see as a pediatric surgeon. So this was in short the wide concept of ideal age of intervention in pediatric urological problems, and I'm open to questions if any.
Thank you, Sandeep sir. You have deliberated a very large topic in a very small time, and we are already lacking time. This is a very interesting topic for pediatricians also, because age limit is a main factor. Many patient comes with, I am explaining two scenario of undescended testes. One baby delivered in our clinic has undescended testes and normally descended at the age of the 3 months. And one patient came at the age of 17 years and parent were arguing कि सर इसको नीचे नहीं कर सकते हैं क्या, हर जगह तो बोल रहे हैं कि अब इसका कोई काम नहीं है, हटा दीजिए. And unfortunately this patient did not came back to me. I don't know where he went for surgery. So thank you.
So this type of outlier things should be avoided in a society. See, the quality of healthcare in a society is decided by these factors. अगर बचपन में उसको reinforce करते करते कि नहीं 1 साल के अंदर सर्जरी हो रही थी, obviously 17 साल तक नहीं होता. I'm not saying that every scenario societies have same thing. Same scenario अगर सिंगापुर में था, अगर I have read that there was lots of inquiry happening कि क्यों miss हो गया certain duration से. So obviously we are not Singapore, but definitely as an individual, as a society level, as a surgical level, we try to imbibe the knowledge in the general population and also in the pediatrician or the community that ideal age अभी है, करा लो नहीं तो बाद में दिक्कत होगी.
Thank you sir for your beautiful presentation and thanks for the opening line कि अगर बच्चा timely operate होता है तो he will have a normal life, because ये बहुत सारे लोगों में misconception है कि if a child is getting operated तो उसको he will be having lifelong some kind of problems. So this must be understood by the society and the treating doctors also.
So this has happened because we are that certain dedicated people who has come into the pediatric surgical care. अगर ऐसा नहीं होता तो पहले तो रिजल्ट खराब ही थे, but you coming to the pediatric surgical setup have improved the result. That's why we are proudly saying कि आप कर दो, लाइफ लॉन्ग दिक्कत नहीं होगा. अगर बस पहले नहीं था, जैसे 17 साल का एग्जाम्पल बता रहे हैं, उसने 17 साल पहले क्यों नहीं कराया होगा? बिकॉज एनेस्थीसिया फैसिलिटीज नहीं थी, इथर था, उस समय रिस्क होता था, बच्चों को लगता था एनेस्थीसिया से बाहर आएगा कि नहीं. ऑल ऑफ दिस सिनेरियो हो गया. सॉरी, आई एम टेकिंग एक्स्ट्रा टाइम.
Sorry, sir, we are running short of time. So,
Thank you so much. Because of the less time we have, we couldn't take the questions. I request everyone, all of you, to please move to the rear side of this auditorium to collect your mementos. And taking the event forward, we are going to discuss one more topic right here: infections in neonates. This is our next topic. And to chair this session, I'd like to invite Dr. Rashmi Agrawal. Dr. Rashmi Agrawal is requested to come and join. Assistant Professor, Pediatrics, NMCH, and also the recipient of Shishu Pioneer Award and Academic Excellence Award, Bihar IAP. Also served as Secretary of IAP Women Wing. You're most welcome, ma'am. Then I'd like to request Dr. Ishraq Parveen ma'am to come and join. She is a pediatric cardiologist and head of Department of Pediatrics at Sadar Hospital, Samastipur, also consultant at Paras Global Hospital. So both the chairpersons have come and joined. And then I'd like to call upon the stage the keynote speaker, Dr. Ruchira Gupta ma'am. And now I request our honorable chairpersons to please give us a short introduction about Dr. Ruchira Gupta ma'am's achievement. Thank you.
Good morning, everybody. First of all, I would like to welcome Dr. Ruchira Gupta, ma'am, our guest speaker from Noida. Ma'am has been the senior consultant at Kailash Hospital in Noida, and all of us all know her. But yes, of course, to go about it briefly, ma'am has been the chief organizing secretary for the National PEDICON 2022, which we all attended at Noida. She has also been the joint organizing secretary for the National PEDICON 2023, national coordinator for many occasions, especially the IAP Women's Swing, the IAP Advanced NRP programs. Ma'am has probably served in all the fields, and she is the chief editor of the IAP UP magazine, that is Child Today. And she also has, to her credit, Applied Spiritual Biology book, which she has contributed to. She has huge contribution in IAP and CD program. And ma'am has been central IAP EB member on several locations. She's been the General Secretary for IAP Uttar Pradesh, and so many credits to her. So we have all experienced her lectures and her presence in almost all the conferences. So over to you, Ruchira Gupta ma'am. A warm welcome from Team PEDICON.
Like this. Thank you very much for the kind introduction, Dr. Rashmi. At the outset, I would like to thank the organizers for giving me this opportunity to share this platform with the august audience. For that, I am truly privileged. And I pay my gratitude to IAP Bihar and IAP Darbhanga. The topic which was given to me is about the challenges in the management of neonatal infection. We are going to walk through this discussion by discussing the challenges in the treatment of neonatal infections. The neonatal mimics, one of our important challenge, case-based discussions and scenarios, and the preventive strategies and some take-home messages. Dear friends, we know that if we talk about neonatal infections, the third leading cause of morbidity and mortality across the globe. And we know that neonates are predisposed for infections due to two obvious reasons. One is because of altered innate and adaptive response to infection, and second is their exposure to unique environmental conditions like maternal colonization, then different IV lines. Sometimes there is a need when IV lines or venipunctures are done, chorioamnionitis, etc., etc. So despite the advent of so many procedures, the management, investigations in the field of neonatology, the challenges still remain in the management of neonatal sepsis. So what are the different challenges? To enumerate some, one by one, that there is no unified consensus on definition of sepsis. If we talk about definition of sepsis, then some people say, some people say that on the basis of clinical features. Then another school of thought says, no, the definition is different. It is when there is a blood growth or growth in the blood culture, then it is sepsis. Now the third people say, okay, now let's define sepsis in a different way. That okay, it is a multi-organ involvement caused by dysregulated host response to infection. So there are different definitions. Coming on to different criteria of early onset sepsis versus late onset sepsis. Again, the challenges. Why the challenges? Because there is no clear-cut guidelines when to call it early onset and when to call it late onset. Some people say, okay, any infection in the neonates which is happening within 7 days is early onset sepsis. But Australian group says that no, it's not 7 days. We'll call it early onset sepsis if there is a blood culture growth in first 48 hours. Late onset sepsis if the blood culture is showing growth after 48 hours. They're very clear about this. When you talk about CDC criteria is 7 days. And when you talk about NICE guidelines, then they say first 72 hours. If there is any blood culture growth in first 72 hours, it is early onset, And after 72 hours, it's late onset. So there is no uniform consensus on discussing about early onset versus late onset sepsis guidelines. Then third challenge is in form of non-specific signs and symptoms and subtle presentation. We all know that newborns, they do not present with fever most of the time. They do not present with different clinical signs and symptoms. Just a sluggish cry, just a letharginess can be the initial presentation of sepsis. And this can be there if there is hypothermia. This can be there if there is isolated hypoglycemia. So these are the challenges to differentiate with the subtle presentations. Then lab parameter interpretation. It's ambiguity and validation issues. For example, if we take about CRP and procalcitonin. So how many of are getting procalcitonin done for investigation of neonatal sepsis? So Dr. Amrita, Dr. Madhusudan, Dr. Chandra Mohan, and Sir Shivbachan Singh, sir. So procalcitonin. But procalcitonin also has got its pros and cons. The advantage is that it picks up sepsis early. And the indication, one of the sepsis screen, which is picking up infection fast. The moment infection happens, within 2 to 4 hours, its levels start rising, reaches peak in next 12 hours, and like that, 12 to 24 hours. Whereas CRP, it takes little time. It takes 8 to 10 hours, or rather 6 to 8 hours to start rising, reaches peak in 24 hours, and then subsequently, further on, it takes its own course. But we know one more fact, that procalcitonin sometimes can be seen high in normal babies also, in first 24 hours. Then how to interpret this? Again, these are certain challenges which are there. Poor yields on blood culture and non-availability of local antibiogram. Now we all know there are so many challenges when we talk about blood culture. Number one, the availability of blood culture facility. Number two, the correct technique of sending it. Number three, the right kind of blood culture bottles. Number four, the way it should be stored. If we talk how to get the blood culture stored, how to store the blood culture bottle, and how to store the blood culture bottle when the sample has already installed or has been put into it. Still, so many people have got doubts in their mind. So these things need to be actually clarified. Though we all know blood culture bottle is to be kept in the fridge, but blood culture, once we have put the sample in it, then it has to be stored once we have put the sample, blood sample, into the blood culture bottle, where should we store this bottle? Any opinions? Some PG students over here. So, no, if suppose pathologist is not available, it's not like suppose sir, we are into peripheries where pathology department gets closed at 8 o'clock, something like that, then how to store their blood culture bottle in which we have put the sample? Never to refrigerate, never to refrigerate. It is always to be kept outside at room temperature. Why so? When the blood culture bottle is empty, we should keep it in fridge. But when we have put the sample, it has to be stored outside at the room temperature. Why? Because we'll have to provide the same kind of conditions for bacteria to grow, which otherwise the bacteria would have got in the body. So never to refrigerate. So these are certain things which are still happening. These awareness programs need to be actually taken. Then local antibiogram. Now, I request everyone, like how many of us, we are working in different institutes or different organizations, how many of us are deciding antibiotics on the basis of local antibiogram? The honest opinion, and it's a sort of knowledge I want to get, that how many of us are actually getting antibiogram made at our local level? So none. So this is so very important. Antibiogram, how will we decide that which empirical antibiotic to be given? A baby who has come with neonatal sepsis. And what has happened now? Somebody in one nursery, they will start with Empigenta. Another nursery will start with Texamamicacin. And the third nursery will start with Piperacillin, Tazobactam, and Amikacin. Who's right, who's wrong, on what basis things are going? Okay, one nursery has started doing Piperacillin, Tazobactam. Should I also start doing it? What is the basis for me to start these antibiotics? Just now we heard Arun Shah sir, his real exemplary oratory lecture on antimicrobial stewardship. This is one of our important factors. We all should have our local antibiogram, and nothing much is required in that. We have to collect samples, at least last 3 month or 6 month samples, and we have to look for the sensitivity pattern, and then we'll come to know which particular organism is growing in our hospital or in our nursery. And this will help us in guiding that which particular antibiotic or empirical antibiotic should be used. So again, there is a challenge for this. Next challenge what we face is Cons growth. So Cons growth is coagulase negative staphylococcus. Now it is a normal commensal, but in newborn it can be pathogenic too. So when it is commensal and when it turns pathogenic, there is a very thin line. Then treatment duration, cases of culture negative sepsis, some say 5 days, 10 days, 7 days. Again, that consensus needed to be finalized. Emergence of resistant bug, Dr. Arun Shah had spoken at a length about this. Again, a problem, and superbugs are really taking over the scenarios. Not only emergence, but what about the treatment? Are we left with many antibiotics? Not really. Sepsis, not only due to viral bacteria, but we know that there are viral sepsis and fungal sepsis. So again, these sepsis mimics are issues. And and lack of surveillance again. So moving on to a case scenario, just these case scenarios are just to highlight upon the sepsis mimics, which we see day and night. A baby, 10-year-old baby boy weighing 2,396 grams, I'm sorry it's milligram, but that's grams actually. A product of cesarean section, uneven full perinatal history, exclusively breastfed, birth weight 2,800 grams, admitted with a complaint of fever for 2 days, refusal to feed, letharginess, and urine output, the parents were not sure. What is the idea? What we might be dealing with? Anyways, we send the lab test in such cases. We sent CBC, CRP, KFT, rapid blood culture, and urine routine and culture. Blood sugar was done instantaneously. It was normal. The working diagnosis was neonate with fever and dehydration. Isn't it? Are we all okay with this? There is a weight loss. It's very clear-cut. IV fluids for correction of dehydration given, IV antibiotics are started, TLC 11,740, CRP2, but urea creatinine were high, and sodium 148. Now what is it? So it is dehydration fever in neonates. After correction of dehydration, baby's cry, reflexes, activity, and feeding significantly improved. And the lab report subsequently showed normal urea creatinine and sodium. The blood and urine culture showed no growth. Final diagnosis was dehydration fever in a neonate, and baby was discharged after 48 hours. This is also one of the sepsis mimic. Moving on, so take-home message with this case is that any neonate who's coming with fever, we should not take it lightly. We should actually admit any neonate who's coming with fever. We might be doing over-admissions, but it is better to observe the baby instead of sending the baby back. Take history of overwrapping, environmental temperature, feeding, urine output, overweight, weight records, and all. And neonate, we all know, might show very limited signs of infection. Thus, a high index of suspicion is mandatory. So, moving on to next case, a 24 days old neonate came with history of fever for 2 days, mild cough, no history of refusal to feed. Baby was active and playful. The family history also showed that one of the sis was having cough and cold. Antenatal, perinatal history was uneventful and baby was breastfed. So, what are we getting here? Most probably our baby is also having viral infection. So, febrile neonate, but viral. Case 3, very preterm, 29 weeks baby, weighing 1100, born to a 29-year-old, primary gravida, spontaneous preterm labor with clinical chorioamnionitis, history of respiratory distress requiring surfactant ventilation at birth, received induction, ceftazidime and amikacin at birth for 7 days outside in another hospital. The patient was brought to us on day 10 of life with PICC line in situ. New onset apneic episodes, abdominal distensions, hemoglobin 14 gram, TLC 3,450, platelet 34,000. CRP 85 milligram per deciliter and blood culture was sent. Antibiotics, since the baby was on ceftazidime and all, so here at our place, antibiotic was escalated to meropenem and amikacin. On day 12, the apneic episodes persisted. Feeding intolerance persisted. Abdominal distension started happening, and there were occasional vomiting episodes. The serial lab parameters showed persistent thrombocytopenia, CRP 65 milligram per deciliter, blood culture on day 3 revealed Candida non-albicans. So, a fungal infection. So, what was the reason in this case? Why the fungal sepsis? Why this baby got predisposed for this? Because of prematurity, low birth weight, unnecessary use of high-end antibiotic, broad spectrum antibiotic. The central lines were there. Mechanical ventilation was given. Then use of H2 receptor antagonist. Again, a predisposing factor for fungal sepsis. Then corticosteroid used, and prolonged stay and parental nutrition. These are other risk factors. But once we diagnose neonatal fungal sepsis, then challenges still remain because we don't have definitive, and nowadays we are finding lots and lots of even resistant fungi. The fungi which is resistant to common antifungals. Then availability of antifungals. Then there are side effects and all. So these challenges are still there. So sepsis mimics, one of the important challenge, we all have to actually see, and we actually encounter them in day-to-day practice: dehydration fever, hypothermia, hypoglycemia, prematurity-related complications like RDS, etc. In modern era of metabolism, CAH, coarctation, etc. However, in all these different entities, there are one or two important salient features which guide us towards these diagnoses, but then yes, they lie in the DD of sepsis mimics. Then infection due to other organisms like virus and fungi, hypo and hyperthyroidism, certain metabolic conditions and congenital infections. Then case 4, the boy Harshit, 12 days old, fever for 3 days, refusal to feed and letharginess, poor urinary output for 2 days, perinatal history uneventful, was admitted in one of the hospital for neonatal jaundice for 5 days and was given IV piperacillin, tazobactam and amikacin for 3 days, and the baby was discharged. baby was brought to us, CBC, CRP, KFT blood culture was sent. CSF decision was pending because parents did not give any decision. We started with meropenem and amikacin, and the TSC showed 3,700, platelet 1.5 lakh, CRP 58, KFT with a normal limit, and sugar was 48. The antibiotic dose was increased to antimeningitic levels, and blood culture revealed Enterobacter resistant to meropenem but sensitive to colistin and phosphomycin. IV colistin was added, given for 3 weeks, baby discharged as a case of neonatal sepsis with meningitis, but it was carbapenemase resistant Enterobacteriaceae. So again, the thing which Dr. Arun Shah was telling, it is really happening, and we are coming across with it. And now we are getting another entity, superbugs, which is resistant to even colistin. We are getting these cases as well. So, take-home message from these cases, there is no need to start unnecessary antibiotic unless there is high index of suspicion. And in babies with prior NICU admissions, we should look for all possible deep-seated infections. Each unit should have its own antibiogram and keep a high index of suspicion of carbapenemase-resistant, gram-negative bacilli, MRSAs, and vancomycin-resistant enterococci. WHO even has also given priority pathogens critical. And we remember that PEA, P is Pseudomonas, E is Enterobacteriaceae, and A is Acinetobacter, because their resistance is emerging very, very high. Coming on to, I will not go into carbapenemase resistance and all. Just, I will require only 1 minute for completing this, because this is important. The challenges with carbapenemase resistant organism, but again, there are challenges with whatever new drugs which are available. That is carbapenemase resistant GNBs drugs. Polymyxin, again, polymyxins has got their own side effects and limitations. Carbapenems, then tigecycline and all. Phosphomycin, amikacin, they have some cannot be given in renal involvement, some cannot be given in neurological involvement because of the poor penetrations and all. Now these are the newer drugs which are available, like ceftazidime, avibactam. These are the drugs which are for the bugs which are resistant to even colistin. Then what to do? Then ceftazidime, avibactam, aztreonam, avibactam, and cefidericol. But again, there are issues because, as Dr. Arun Shah had told in his lecture, that there is not even a single mechanism of development of antibiotic resistance. There are multiple mechanisms which are happening. So one drug which is covering all different sort of mechanisms which are causing resistance is needed. Do we have one? Not really. So these are the challenges. So the final words are that carbapenemase resistant gram-negative bacilli, methicillin resistant Staph aureus, and vancomycin resistant enterococci, they are the emerging threat to hospitalized patients. Every unit should have its own antibiogram. Culture, we all will have to develop a culture of sending cultures. The treatment options are very limited. Appropriate interpretation of culture reports, again, a challenge, an issue. Choice of appropriate colistin-based therapy, attention to drug dosing and surveillance of drug side effects is mandatory, and keep a high index of suspicion for sepsis mimics, and attention to infection control method is, again, the first and foremost thing which can help us in preventing, in development of these superbugs. So with this, I would like to end my presentation. I would like to thank you for your patient listening.
Thank you, Dr. Ruchira Gupta ma'am. It was very elaborated topic. Actually, you made it very simple and presented it in just, but we want more of it, but because of time constraint, we have, but it was very informative and very enlightening.
Thanks for the kind words.
We don't have time for question answer sessions, so we may proceed with the next one. Thank you so much.
Thank you.
Thank you so much, ma'am. I'd like to request you and both the chairpersons to move to the rear side of this auditorium to have the memento. And there is an important announcement. We have started lunch, so anybody who is willing to have lunch may proceed. And then moving to the next topic, we are going to have the next topic, antibiotics and probiotics. Let's be holistic. This is going to be our next topic. And to chair this session, I'd like to invite Dr. Bhupendra Narayan, sir, the Head of Department of Pediatrics at PMCH. Also, Dr. Parmeshwar Kedia, the Additional Director of Department of Health, Bihar. And the third chairperson, Dr. Sushil Kumar, the Associate Professor at Department of Anesthesia, DMCH. Again, I'd like to repeat. Our first chairperson, Dr. Bhupendra Narayan. Our next chairperson, Dr. Parmeshwar Kedia. And our third and last chairperson, Dr. Sushil Kumar. And one of the chairpersons has joined. I'd be requesting the rest of the two to please come and join so that we can start further. The next topic that we are going to cover it right now is antibiotics and probiotics. Let's be holistic. And also, I'd like to request anyone who is willing to have lunch may proceed.
डॉक्टर उद्भट मिश्रा को कर दो डॉक्टर उद्भट मिश्रा है ना एमडी पीडिया में
Dr. Udbhatta Mishra is requested to come, the MD Pediatrics and eminent pediatrician of Darbhanga. Sir, you are requested to chair this session. Dr. Udbhat Mishra. So we are going to begin this session with two chairpersons, and now I request our honorable speaker, our keynote speaker, Dr. Piyali Bhattacharya, to please come. And our next topic, as I have already told, is antibiotics and probiotics. Let's be holistic. Thank you so much. Over to the chairpersons. Thank you.
Thank you, organizing committee, for providing me the chairperson for this. I am feeling proud for the chairing the session of such a eminent pediatrician, Dr. Piyali Bhattacharya, who is at present attached to SGPGI Lucknow, and she has been awarded with Fellowship of Royal College, London in 2019, Fellowship of IAP Pediatrics in 2025, award Fellowship the Indian Academy of Pediatrics 2025, the State Awards UP IAP, and National Winner Jagran Awards for Excellence in the Field of Social Service. And she has many publications, national, international, and author of 27 books chapter, national member, National Advisory Board, Journal Indian Pediatric 207, member, she has a very big list of his, so, and she is going to discuss a very important topic, antibiotics and probiotics relation and its usage. So, madam, it is very interesting thing. And now I'm handing over mic to Dr. Mishra.
I'm sure that this is going to be a great presentation, and this is a very relevant topic in our society, in our pediatric society right now. So I request Madam to continue. Thank you.
Thank you, sir. Uh, Heartfelt thanks to IIP Bihar. Thank you for calling me for this prestigious session at the PEDICON in Bihar. In fact, I was not here, I was in Assam, so I rushed here so that I could participate at this prestigious occasion. Thank you so much. Tahe dil se, thank you. When we talk about antibiotics, in fact, I believe the whole morning we've been talking about antibiotics, use, disuse, misuse, all of them. So, once we talk about the holistic use, then we need to think कि antibiotics करना है कहाँ, नहीं करना है कहाँ, अगर करना है तो और क्या कर सकते हैं. So when we talk about holistic use, you know, we talk about first the human microbiome. माने सर से पैर तक हमारे अंदर how much of microbiota do we have? मतलब अब आप जब घर जाएंगे तो प्लीज़ रिमेंबर आपका 1 किलो वज़न, आप ओबीज नहीं हो, आपका वज़न ज़्यादा नहीं है, 1 किलो वज़न सिर्फ माइक्रोब्स की वजह से है. सो घटा लीजिएगा उसको अपने वेट में से. So the microbes from head to toe, we have a lot of microbes, and you can see over here that it is defined as organisms which are interacting with the human body. तो ये माइक्रोब्स जो हैं ये हमसे बातें करते हैं और हमारी बॉडी इनसे बातें करती है. सो दे आर वेरी वेरी इम्पॉर्टेंट फॉर आवर बॉडी, एंड द इंटरैक्शंस बिटवीन दीज माइक्रोब्स एंड आवर बॉडी play a very important role in maintaining homeostasis in our body. So gut microbiome out of this. When we talk about gut microbiome, remember we have 100 trillion bacteria inside our guts. So having said that, they have a key role, and the composition of these microbiota actually matter in how our gut functions. पेट ठीक तो सब ठीक. बंगाली में कहते हैं तो पेट में ठीक पड़ेगा तो पीठ भी उसको सहेगा. So if you have got a good gut microbiome, remember it is a highly individualized composition. आपके में जो होगा ज़रूरी नहीं है कि वही मेरे में हो, मेरे में जो होगा वो सर में हो, ऐसा ज़रूरी नहीं है. So it's an individualized microbiome, and it depends on a lot of things which we will talk about later. And सिर्फ अगर आप genetics की बात करें तो it is not genetics, maybe 20 to 30% of it is genetics, but all other factors like 70% of environmental factors also work there. And बहुत important है what is a diet, which is driving, which is a major driver in the microbiome constitution of our gut. जब हम functions की बात करेंगे तो number 1 is metabolic function. Metabolic function माने short chain fatty acids, digestion, breakdown of polyphenols, and then bile acid metabolism. That is one thing where it acts very much. अब आप defensive action की बात करोगे तो defensive action में many of these microbes actually produce bacteriocins, vitamins, and then they give us they also stimulate the IgA secretions. So that way they will actually be responsible for enhancing defensive mechanisms. And the third is the trophic function. So this is again a regulation of the intestinal epithelium. So when we say that, आप ये समझ लो कि रोटी कपड़ा और मकान की लड़ाई है यहाँ पर. मतलब आप माइक्रोब्स को रोटी दोगे या अच्छे वाले माइक्रोब्स को दोगे, आप बुरे वाले कीटाणु को दोगे, उसको रहने दोगे, या मकान दोगे आप अच्छे वाले कीटाणु को. सो रोटी कपड़ा और मकान की लड़ाई हर जगह चलती है. अब जब आप डिसबायोसिस की बात करोगे, then dysbiosis refers to an imbalance of the gut microbiota which has significant health implications. अगर आप adolescents को देख लो, they consume a lot of junk food, and that is why जो adolescents कभी हमारी OPD में नहीं आते थे except for maybe a few sports injuries, they are now coming repeatedly to our OPDs. Dental caries, myopia, gut disbalances, diarrhea, they come with all these things. Either dard, udar dard, peeth mein dard, haath mein dard. So these people are also coming because there is a lot of junk intake in adolescents. अब जब डिसइक्विलिब्रियम हो गया तो जो हमारे अंदर अच्छे वाले फूड फ्लोरा हैं, दी कमेंसल्स, दे आर लॉस्ट इन द सेंस दैट कई तरह के होंगे, ए बी सी डी बहुत होंगे, उसमें जब कीटाणु घुस जाएगा तो ए बी गया, बी बी गया, सी बी गया, वहाँ सिर्फ कीटाणु आ गया, एफ 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 भर गया. सो दे नाउ बिकम पैथोजेनिक. अब जब पैथोजेनिक हो गए, क्यों पैथोजेनिक हो गए, क्यों बुरे वाले कीटाणु बढ़ गए? सो यू हैव एंटीबायोटिक्स एज अ मेजर फैक्टर ऑफ दीज dysbiosis that is occurring. So other than that also, as I said, there are several factors including stress जो हम सभी को है, diet, as I said, junk food and hygiene. Ruchira was saying कि हाथ धोना is probably the best thing that we can do to prevent any other problems. अब आप देख लो कि हर जगह पे डिसबायोसिस का इफेक्ट होता है, इंक्लूडिंग टुडे वी आर टॉकिंग अबाउट मेंटल हेल्थ. हर आदमी देखो डिप्रेशन में चला जा रहा है. यू हैव दिस माइक्रोबायोम which crosstalks, even there is a brain gut axis as well. So remember that शरीर ठीक नहीं तो कुछ ठीक नहीं, and you may be in depression because of dysbiosis also. Now, as I said, a grave threat to human health is antibiotic resistance. And antibiotic resistance mein, we are having around 1.3 million deaths. In South Asia, you have seen the number, 3,89,000 deaths. Sub-Saharan Africa, we have 2,55,000 deaths. So that is the extent of deaths that we are having due to antibiotic resistance. Now, antibiotics, I don't have to discuss this with you. Antibiotics will actually, the normal gut biota will be disturbed, number one, by the length. तो अब बोल रहे हैं कि 3 दिन amoxicillin दो, 7 दिन मत दो. Why? Because the length of antibiotics will actually sort of influence the microbiome. What is the route of administration, whether it is oral, whether it is IV, whether it is IM? And remember, आप IV भी दोगे या IM भी दोगे, it will be secreted a little bit in the gut, so thereby affecting the gut microbiome. Not only that, क्या pharmacokinetics है, ड्रग से रेजिस्टेंस है कि नहीं, डोजेज आप ठीक ठाक दे रहे हो या आप रेजिस्टेंस पैदा कर रहे हो, एंड देयर आर अदर कंफाउंडिंग फीचर्स, एज आई सेड, कि बहुत सारे अदर फीचर्स भी हैं. तो यहाँ पर मैंने एक यूज ऑफ एंटीबायोटिक्स करने से क्या होता है ये दिखाया. जब नो एंटीबायोटिक्स होते हैं तो 10 तरह के माइक्रोबायम्स होते हैं, एंड दीज ऑल हेल्प इन डिफरेंट वेज ऑफ फंक्शनिंग. पर जब आपने एंटीबायोटिक दे दिया, देखिए ब्लू बढ़ गया, तो बाकी सारी खत्म हो गई. सो दोज फंक्शनल माइक्रोबायोम्स आर लॉस्ट ड्यू टू द एंटीबायोटिक, एंड देयर इज अ चेंज. सो चेंज में क्या हो गया, शॉर्ट टर्म यूज कर रहे हो या लॉन्ग टर्म यूज कर रहे हो, प्रोग्रेशन ऑफ रिलेटेड डिसऑर्डर्स. अब रिलेटेड डिसऑर्डर्स जब हम कहते हैं तो कौन से डिसऑर्डर्स हो जाते हैं, आप वहाँ देखो. सबसे ज़्यादा डर किस बात का है कि एक्सपोजर टू एंटीबायोटिक्स, एंड एक्सपोजर होने के बाद आपका हो गया susceptibility of certain strains with acquired resistance. और एक बार अगर resistance acquire कर लिया, this resistance is now genetically transmitted to the other microbes as well. So that is the real khatra, the real problem of the antibiotic resistance. So अकेला एक जना नहीं resistant हो रहा है, वो दूसरों को genetic material transfer करके उनको भी resistant बनाए दे रहा है. Now, therefore, what do we have? We have now got a reservoir of antibiotic resistant genes now. So अब आप क्या करोगे, because in the next 20-30 years maybe we will not have new antibiotics. So एक बार आपने antibiotic दिया तो आपने diversity को deplete कर दिया, आपने intrinsically selection किया किसका ना, resistant bacteria रह गया आपके पास. So these will give altered gene expression, protein activity, and will affect the overall metabolism, and of course selection for new mutations and gene transfers, conferring further resistance again. अब आपने diarrhea as a consequence, we all know कि diarrhea as a consequences of associated dysbiosis होता है, we've all seen that, AAD antibiotic associated diarrhea. Now over here there is just one point which I would like to stress upon. If you have given an antibiotic and you want to give an adjunct probiotic, I will say adjunct, please note my words, then it should be started on day 1 of antibiotic, dose 1 of antibiotic, not after 2 days of antibiotics. So agar aap saath mein dete ho, only then you will get a holistic effect of that probiotic which you have added. Now consequences of disruption with antibiotic. Puri zindagi, you see a charted out. The dotted line is when you are giving short terms of antibiotic. The long line is given when you've given 1 dose of full course of antibiotic. तो आपने देखा जन्म से birth to loss of mobility तक, last तक आपका antibiotics will affect the development and into adulthood. So it's got a huge implication if you are giving an antibiotic. And the critical consequences can be short term and long term. So mainly what are in pediatrics, what are we worried about short term antibiotic associated diarrheas, followed with which what happens, एक बार उनका gene resistance, what grows then, जो कीटाणु आ जाता है, that is Clostridium difficile. And Clostridium difficile के लिए अब तो हम लोग क्या कर रहे हैं, Helicobacter pylori, Clostridium difficile, और ठीक ही नहीं होते हैं, into adulthood उन लोगों को डायरिया चलता ही रहता है. You do not think that if you have stopped the antibiotic, the diarrhea will go away. No, it happens so that it continues and continues in many people if you have repeatedly given antibiotics since birth. Now, इन लोगों में हम लोग क्या कर सकते हैं, कुछ भी ज़्यादा नहीं कर सकते, तो FMTs करना पड़ता है. अब तो स्टूल खिलाया जा रहा है लोगों को, ऐसे लोगों को जिनमें बहुत अच्छा हैबिट है फूड का, उनको सहेजा जा रहा है जर्सी गाय की तरह, और उसके बाद उनके स्टूल को कैप्सूल में भर के FMT मतलब स्टूल ट्रांसप्लांट्स किए जा रहे हैं, फीकल मटेरियल को ट्रांसप्लांट किया जा रहा है ओरल कैप्सूल्स के फॉर्म में आटी डाल के. सो अब ये हो रहा है जिनमें क्रॉनिकली ऐसे एसोसिएटेड डायरियाज रह रहे हैं. नाउ इफेक्ट ऑफ वेरियस, आई हैव शोन यू हर एंटीबायोटिक का इफेक्ट है, विच क्लास एंड व्हाट इज द इफेक्ट. आप देखो ऊपर वाले अच्छे ज़्यादा होंगे तो नीचे वाले कम होंगे, और नीचे वाले कम होंगे तो दे आर गुड बैक्टीरिया, लैक्टोबैसिलाई, आपके बिफिडोबैक्टीरियम, ये अगर कम हो जाएंगे, एंड ऊपर वाले जो डीप ग्रीन में हैं, इफ दे बिकम मोर देन यू आर प्रोन टू इश्यूज ऑफ डिसबायोसिस. सो इसमें देखो आप, इसमें भी दिए हैं मैंने कार्बापेनेम्स, क्विनोलोन्स, मैक्रोलाइड्स, ऑल ऑफ देम. सो व्हाट द मैसेज शुड गो इज दैट unless necessary, please avoid antibiotics. And what are the interventions then? How can we be holistic in selection of antibiotic resistance, for antibiotic resistance? उसमें आपको देखना पड़ेगा कि what are the alternatives. Alternatives में देखिए बीच में है phage therapy है, बैक्टीरियोसिंस अलग से देने का है, आपका फीकल माइक्रोबायोटा ट्रांसप्लांट मैंने आपको थोड़ा सा बोला, यू हैव ऑल्सो गॉट मोनोक्लोनल एंटीबॉडीज, बट दीज आर ऑल वेरी वेरी एक्सपेंसिव एंड नॉट अवेलेबल एवरीवेयर. सो आपके पास बचा मिडल वाला कि आप प्रोबायोटिक्स दो. पता नहीं हमारे पूर्वजों को कैसे ये बातें पता थी, वो दही हर उसमें रखते थे. सो दे, आई डोंट नो द डोजेस क्या थे, उनके साथ उनकी विद्या शायद चली गई, but they knew that probiotics are important for diet. अब they manipulate the, मैंने जैसे कहा रोटी कपड़ा और मकान का प्रॉब्लम जो है वो सॉल्व करते हैं. कैसे सॉल्व करते हैं? They attach themselves to the sides and thereby don't allow the other जो गंदे कीटाणु होते हैं उनको अटैचमेंट करने ही नहीं देगा, तो कैसे करके होगा? Not only that, they eat the material provided, तो गंदे कीटाणु को खाना ही नहीं मिलेगा तो कैसे होगा? तो वही रोटी कपड़े और सवाल हो जाता है. सो इफ यू हैव गुड बैक्टीरिया in your tummy, the other bacteria will not be able to grow. So आपका जो है probiotic mechanisms are actually, they enhance the epithelial barrier by their trophic actions. There's an increased adhesion to the intestinal mucosa. There's an inhibition in pathology. जब जगह ही नहीं मिलेगी, receptors ही नहीं मिलेंगे, how will the pathogens attach? And there is a competitive exclusion of the pathogens. So there is a reduction of gut inflammation, there is a modulation of the immune system, and thereby gut dysbiosis is reduced. अब आप देखो health and clinical targets of probiotics. In the left hand side, see, from infant, child, adult, everywhere there is disease which can be targeted. These are the clinical targets. So you can target this with probiotics across the whole life stages, चाहे वो neonate हो, newborn हो, चाहे वो adult हो. So there are so many studies now, meta-analysis of probiotics with antibiotics. There were so many studies which say that there is a reduced timing, there is a reduced length of stay, there is reduced economy, and thereby the Bacillus clausii, which has now been studied. I was part of a huge study across India as well. This is a frequently used probiotic, and it has been shown to prove good in the gut dysbiosis. So the recommendations are that आप साथ में दो, साथ में start करो, and from my experience I would say that 3 days of therapy is sufficient to help in viral diarrheas or in antibiotic associated diarrheas. The clinical studies in various infections with Bacillus clausii has been done. So you can see a host of things: Helicobacter, rotavirus, necrotizing enterocolitis, upper respiratory, allergic rhinitis. And not only that, there are so many of these studies still in action, going on. And the change in composition after treatment has been scientifically shown. So we have changes. So when summarizing the thing, I would say that आपको antibiotic use करना है, तो there should be compelling evidence that आपको antibiotic use करना है. Don't use it injudiciously, and excessive use will foster a bacterial resistance. Probiotics will alter the composition of the gut flora and thereby form a harmonious atmosphere. Bacillus clausii has been documented to show efficacy, and clausii is also recommended by an Asian expert panel for acute, chronic, and antibiotic associated diarrheas. With that, I rest my presentation. Thank you so much.
Thank you, madam, for your nice, compact, and knowledgeable deliberation. And you have proved your name of प्याली. हम दो प्याली का नाम जानते थे, एक चाय की प्याली होती है और एक सुरा की प्याली होती है. एक ज्ञान की भी प्याली होती है, ये हम नहीं जानते. there's a nadi also called Piyal and Kamal, 2 trees. तो ज्ञान की, आप तो ज्ञान की प्याली हैं, ठीक है. और आप जो रोटी कपड़ा मकान की बात बता रही थी वो तो है ही, लेकिन डॉक्टर के साथ एक और बात जुड़ रहा है, रोटी कपड़ा मकान और अपनी दुकान, और उस अपनी दुकान के चलते जो है सो कुछ एंटीबायोटिक्स का मिसयूज हो जाता है. So thank you, madam, for your nice deliberation.
Thank you so much, ma'am, for your nice presentation. Before presentation, I thought that there was lots of question in our mind that might come, but after presentation, you covered anything and everything. Thank you very much.
I was listening your lecture, not as a doctor, but as a layman. My intention was, so this lecture is equally important and useful for the lay persons. We can, during the lecture of Dr. Arun Shah, we learned about antibiotic resistance. And that lecture and your lecture is very much common things. And this message should go to the community also, so that they can challenge us when we have prescribed any antibiotic. The doctor साहब मुझे antibiotic क्यों लिखें, क्या इसके बिना मेरा काम नहीं चल सकता? जब तक ये क्वेश्चन हमारे साथ नहीं आएंगे, तब तक शायद हमारी हैबिट नहीं छूटेगी. Thank you.
सर वो खा के ही आते हैं, 2-3 तो खा के आते हैं अपने आप से और पुराना प्रेस्क्रिप्शन देख के खा के आते हैं कि आपने पिछली बार ये दिया था, इस बार भी हमने ये खा लिया है, काम नहीं बन रहा है, अब बताइए दूसरा कौन सा खाना है।
अब हमारा जवाब होगा कि अब आप सब छोड़ दीजिए, you will be cured. Thank you so much.
Thank
So
you.
nice present.
डॉक्टर सुशील का हमेशा रहता था जो ये रहता था हमेशा कि ये प्रिस्क्रिप्शन उसी समय के लिए, अगली बार के लिए नहीं है। जो बीमारी सोच के आप दवाई खा रहे हैं उसकी दवाई उसी बीमारी के लिए जो अभी आई है सो लिखी हुई है। तो डॉक्टर सुशील कुमार इज ऑल्सो ए वेरी प्रोपोनेंट ऑफ द प्रोबायोटिक्स एंड रिस्ट्रिक्शन ऑफ दिस एंटीबायोटिक्स। सो योर थॉट्स आर हिज थॉट्स टू।
And thank you so much to the speaker and thank you so much to the chairpersons. I request everyone to move to the rear side of the auditorium to collect the memento. Thank you. And let's now start our final segment, which is the oration. So let's move to the Dr. O.N. Jaiswal oration. We are about to start Dr. O.N. Jaiswal oration, for which I am very privileged to announce the name of the chairperson, Dr. S.A. Krishna, who is ex-head of Department Pediatrics at NMCH and has been the president of East Zone IAP. So first of all, I'd like to request
May I call upon stage Dr. S.A. Krishna, the legendary Dr. S.A. Krishna, ex-HOD NMCH, has been President East Zone IAP and has been recipient of many awards at national levels. So, please join your hands for Dr. S.A. Krishna. And may I call upon stage Dr. Madhu Sinha, Honorable Secretary, IAP Bihar Chapter. And the oration is Dr. O.N. Jaiswal oration. And the speaker for this is Dr. B.P. Jaiswal. The topic is an approach to a case of anemia. So a big round of applause for Dr. B.P. Jaiswal.
Let me say about our Dr. Professor O.N. Jaiswal ji. He was born on 7th December of 1930 and gone heavenly abode on 15/4/2004. He was ex-professor and head, upgraded Department of Pediatrics, Patna Medical College, Patna. His academic qualification is MBBS, honors in pathology, Patna Medical College, 1954 University and college merit scholarship from Patna University. He was trained at UNICEF Fellows Institute of Child Health in 1964-65 as senior teacher of pediatrics, University of London, UK. Short orientation course in neonatology, Postgraduate Institute of 1968, organized WHO, UNICEF at Chandigarh. WHO Fellowship for Postgraduate Medical College in 1978, remodeled pediatric curriculum, Jabalpur. Colombo Plan University of Dundee, UK, 1979. He was expert in Union Public Service Commission, New Delhi, Public Service Commission, Tribhuvan University, Kathmandu, Nepal University. He was the Dean Faculty of Medicine, Patna University, member Sonata Syndicate and Academic Council, Patna University, member of Postgraduate Research Council, Patna University, member Faculty of Medicine, Patna University, member Board of Courses, Patna University, Magad University, as well as Banaras Hindu University. In the national program, LCDS consultant for training, orientation, and continued education, EPL principal investigation of MOSI vaccine trial project, school health program, and professional activities are so many, and I will request Dr. Madhu to say about Dr.
Hey, Kunal.
Good afternoon, everyone. And I really feel privileged and honored that I have been given this opportunity to co-chair this prestigious Dr. Owen Jaswal oration with my teacher, Professor S.A. Krishna, sir. So I'm really touched and feel blessed. Now, the turn is to introduce our speaker for this prestigious Dr. Dr. Owen Jaswal oration. And the speaker for this is none other than our Professor Dr. B.P. Jaswal, sir. Sir is a professor at Nalanda Medical College, and he has done MBBS, MD Pediatrics, DCH, and he is FIAP. He is presently working as professor at NMCH Patna. His areas of special interest are respiratory and cardiology. Various publications can be credited to his name in national as well as international journals. Sir has been awarded with so many awards. From his zone, he has got Pioneer Award as well as Shishu Visheshagya Ceremony Award. Then he got Lifetime Achievement Award from IAP Bihar. Has delivered many orations in IAP Bihar as well as national conferences. And he has adored many posts in IAP Bihar. To name a few, sir has been Secretary IAP Bihar, President IAP Bihar, and presently he is President of IAP Patna. So I request sir to proceed with his talk.
Thanks. Thanks, Dr. Madhu, for your nice words. And good evening, Professor S.A. Krishna, my teacher, and all renowned pediatricians who have assembled over here. This is my proud privilege, and I feel honored while giving this oration in honor of late Professor Owen Jaswal. I had my association with him for at least 10 years. I got my MBBS from Patna Medical College, and I got my MD Pediatrics from there. And I should share with you only 4 or 5 things about him. Then I will start this topic in his honor. He was a disciplinarian, he was an academician, and a human being par excellence. He was always sticking to time, and he used to come in the department at 9 a.m. sharp. And many of the students and teachers, they used to be very alert that they should reach the department by 9. And he used to start the round at a fixed time. 9:30 he will start. Professor Krishna sir, who had been my teacher as well in PMCH, he will agree with me. And he was a fatherly figure, I should say. And so many things I have to narrate because I was there in PMCH, Patna Medical College, for more than 10 years. But paucity of time, I am rendering this talk of mine in his honor and in his respect. Now I have chosen a very common topic that all of you will appreciate, that is an approach to anemia in a child. You know, anemia is very common, and it will be just anemia revisited for you all. For the postgraduates, though of course there are not many here in the hall, it would have enriched their knowledge as well. Now, definition. Anemia is defined as a reduction in the blood hemoglobin concentration to standard deviations below the mean for the normal population with respect to age and gender. You will have to appreciate that you consider anemia in relation to age and gender of the patient. Now, in India, according to Family Health Survey data, the incidence of anemia, that is between 6 to 59 months, you can see the data, NFHS 5, 2019 to 21, it was 67.1%. And according to 4, it was 59%. You can well appreciate how common anemia is in our society. Now, WHO has given cutoffs for labeling anemia. It will not depend upon your whim that you will label a child to be a case of anemia, or you will not label, you can't or you shouldn't label a child without anemia. It is not upon your whim and your clinical judgment. Rather, the cut-offs that must be remembered by the pediatricians. Now, you see children, 6 months to 5 years, it is less than 11 gram %. And children 5 to 11 years, less than 11.5. And in male, you see at the last, it is less than 13 gram %. And female, 15 to, 19 years, it is less than 12. I'm having some pharyngitis, therefore please bear with me. In listening to me, you will have to be very cautious. Now, clinical features. All of you know what are the clinical features. But the earliest clinical features and the late complications of anemia must be remembered. Now, in the early phase, early part of anemia, the child will have tiredness, easy fatigability, generalized muscle weakness, loss of appetite, poor feeding, irritability, and inadequate school performance. Scholastic performance will diminish. Now, in severe anemia, the clinical features will vary. All of us know that if anemia is very severe, there is every chance of heart failure. And features of heart failure may ensue. Now, what are the features? Shortness of breath, palpitation, tachycardia, postural hypotension, dizziness, headache, lack of concentration, androgynous, and clouding of consciousness in the end. Therefore, we pediatricians must appreciate the clinical features in severe anemia. Only then you will institute the right treatment and the life of the child will be saved. Now, also in rapidly developing anemia, as for example, acute hemorrhage, symptoms develop at higher hemoglobin level. Let me tell you that if hemorrhage is there, blood loss will be very fast. Therefore, the symptoms of anemia will develop fast because the heart will not have the time to compensate for the diminished hemoglobin level. In chronic anemia, generally, clinical findings appear when hemoglobin fall below 7 to 8 gram %. But at this juncture, let me tell you, and particularly the students, that hemoglobin consent, please don't always stick to 7 gram, 8 gram as a cutoff for blood transfusion. A child with 7 gram % of hemoglobin might be comfortable without any feature of congestive heart failure. You need not go for blood transfusion. But a child with 8 gram or 9 gram % of hemoglobin might be having features of congestive heart failure, and you will have to go for blood transfusion. Therefore, you should appreciate the clinical features of heart failure and the hemoglobin level, of course, 7, 8 gram %, that cutoff is important. But clinical, you should pay attention to the clinical features the child will be having. Now, what should be our approach to anemia? History, physical examination, complete blood count, reticulocyte count, and peripheral blood smear. Now, clinical feature, age, neonatal blood loss, all of us know, feto-maternal hemorrhage, hemolytic disorder. In childhood, 6 months to 3 years, nutritional anemia is very common. And after 6 months, beta thalassemia, you should look for. Now, sex is also very important because many diseases, in many diseases, females are the carriers. And the diseases, they do manifest in the males. Therefore, in X-linked diseases like G6PD deficiency, all of us know, and pyruvate kinase deficiency, male will be affected. And similarly, history in male siblings, maternal male, cousins, maternal uncles, and maternal grandfathers, in them, the disease may come in males. In adolescent females, as a result of menstrual loss. Therefore, sex is also important while you are evaluating anemia. Family history, that is important, autosomal recessive, hemoglobinopathies, and thalassemia. That is the mode of inheritance. Autosomal dominant, hereditary spherocytosis, chronic hemolytic anemia, history of anemia, gallstones, and blood transfusions. If repeated blood transfusion is going on, then you should be alert that, this could be a case of hemolytic anemia. Now, dietary history is also very important in the causation of anemia, like nutritional iron deficiency anemia, poor breastfeeding, and improper time of weaning. Weaning is done after 6 months. All of us know it. But in many parts of the country, and in many parts of Bihar as well, mother goes on giving milk only, and milk is a very poor source of iron. And they don't start, semi-solid food and prepared food. Therefore, anemia is precipitated. Bottle feeding is also a very bad, habit the mother adopts. In megaloblastic anemia, vegetarian diet and goat milk. And all of us know that goat's milk is a poor source of folic acid. And this will cause, megaloblastic anemia. Iron deficiency anemia, the habit of pica. Pica is eating of inedible substances. Therefore, that will also lead to anemia. Infections, marrow suppression. If it is there, then anemia will come up. In marrow suppression, viral infections, they are very important. Like EB virus, cytomegalovirus, parvovirus, falciparum malaria, kalajar, fulminant sepsis, nutritional anemia like hookworm infestation, causes malabsorption, nutrient deficiency, and microbleeding. This is also very important that you should appreciate. There is microbleeding in the intestine in hookworm anemia. And, in kalajar, the bone marrow picture will be pancytopenia. All series of cells will be depressed. So you should know, you should appreciate it. Drugs, salicylate, NSAID, chloramphenicol, and group का जो medicine है, ये decreased production due to hypoplasia of bone marrow. I am telling you the causes of anemia. What are the causes? In our day-to-day practice, we are using penicillin, nitrofurantoin, primaquine, and miltefosine. All these drugs will lead to, and may lead to rather, I should say, hemolysis. And lastly, phenytoin and folate antagonists. Folate antagonists are the, methotrexate and certain antimetabolites. They are folate antagonists and they will lead to megaloblastic anemia. Now, physical examination is very important because many a times your clinical acumen will lead you to diagnosis. And then you will confirm the diagnosis by investigation. You shouldn't rely always on the investigations. Therefore, pallor is the most common, prominent and characteristic features. And sight of seeing pallor, let me remind you, all of you know, but let me remind you that lower palpebral conjunctiva, dorsum of tongue, oral mucosa, palmar and plantar creases, and nail bed and skin. These are the common sites that you should go for evaluating anemia. And grading of anemia, if you do remember, it's so good. Only moderate and severe anemia you can grade. In moderate anemia, pale mucosa and pink palmar creases are there. But in severe, faint and pale palmar creases are there. Therefore, palmar creases, आपको anemia का feature मिल रहा है, तो मान के चलिए ये severe है, and be alert. इसलिए इसी को आपको देखना है. Now phases, there are certain typical phases in anemia. I'm just correlating anemia with some important, association. Like hemolytic phases, all of us know, frontal and parietal bossing, large head, depressed nasal bridge, malar prominence, irregular maxillary teeth. Hemolytic phases are typical because of extra hematopoietic activity. Bone marrow is suppressed, therefore, maxilla and all these bones, they take up the lead for producing. No, in oration there is no time, 40 minutes. Okay, it is not 25 or 20 minutes. Now, in eyes, you can well appreciate that microcornea, Fanconi's anemia. If you are getting microcornea, then you should associate it with Fanconi's anemia. Conjunctival vessels, tortuosity, retinal hemorrhage, you can associate it with sickle cell anemia. Blue sclerosis is there. What you will think of? You should think of iron deficiency anemia of severe grade. वो उसमें blue मिलेगा. K surfacing, I need not tell you, Wilson's disease, icterus in absence of high colored urine. This is important. High colored urine है, नहीं है, और icterus है, तो सोचिए कि ये hemolytic anemia हो सकता है. Now, oral cavity में glossitis, angular stomatitis, bald tongue, nutritional anemia, teeth malocclusion, hemolytic anemia, cleft lip palate मिले, diamond black fan syndrome. In diamond black fan syndrome, there is, congenital pure red cell aplasia. Pure red cell aplasia, along with, some congenital bony deformities. Pigmentation, pew jaggers, I did not go in details. Now skin changes, hyperpigmentation, नकल हाइपरपिगमेंटेशन को याद रख लीजिए आप लोग, मेगालोब्लास्टिक एनीमिया होगा नकल में यदि हाइपरपिगमेंटेशन मिले. विटिलिगो, देयर इज विटामिन B12 डेफिशिएंसी. इक्टरस, लिवर डिजीजेज, हेमोलिटिक एनीमिया. नॉन हीलिंग अल्सर्स ओवर लोअर लिम्स, this is hemoglobin sickle cell. Now nail changes, I need not tell you, lymphadenopathy, significant lymphadenopathy, tuberculosis, HIV, infectious mononucleosis, leukemia, lymphoma. Significant hepatosplenomegaly along with anemia, mind you. तब क्या सोचेंगे आप? Hemoglobinopathies, malaria, कालाजार, tuberculosis, HIV, leukemia, thalassemia and other lymphoma. Isolated splenomegaly मिल रहा है आपको along with anemia. Anemia, isolated splenomegaly, what you will think of? Enteric fever, malaria, immune hemolytic anemia, congenital spherocytosis, portal hypertension, lymphoma, chronic myeloid leukemia, tropical splenomegaly, or hypersplenism. Now, this is the laboratory approach, and because of paucity of time, let me tell you that you should have an analytical approach while diagnosing anemia. And the cause of anemia must be ascertained. Otherwise, how will you treat? Anemia is just खून की कमी, hemoglobin की कमी. लेकिन किस कारण से हो रहा है? You will have to know. Therefore, this is the flow chart for the lab approach, and you can go through it. Now, further evaluation and confirmatory test. All these tests you can read. Review dietary history, serum ferritin, iron, total iron binding capacity, and diet. And all these tests you will have to go for. Though these tests might appear cumbersome to you, but they are very simple and you can analyze. थोड़ा सा आप वक्त देंगे एनीमिया पर तो आप समझ सकते हैं कि किधर आपको जा रहा है. स्क्रीनिंग टेस्ट CBC, हेमाटोक्रिट, RBC indices, MCB, MCH, MCSC, and red cell distribution width, reticulocyte count, peripheral smear. Now, what are red cell indices? Yes, these are the quantitative measurements of red blood cell. The amount and concentration of hemoglobin in them. ये बताता है ये कि कितना hemoglobin है RBC में. तो you will have to know. Mean cell volume, volume को बताता है. MCH को I will let you know in brief. Now, MCV, it is the mean corpuscular volume, not mean cell volume. Mind you, it is the measure of average volume of RBC. That is, you can calculate it very, very simply. MCV is equal to hematocrit into 1000 divided by RBC count into 10 to the power 12 per liter. Normocytic, macrocytic, macrocytic. You may remember, if you feel comfortable, that macrocytic is more than 100 fem to liter. से ज़्यादा होगा तो हम मैक्रो बोलेंगे और नॉर्मोसिटिक 80 to 100 और 80 से कम होगा MCV तो हम कहेंगे कि माइक्रोसिटिक है. थोड़ा सा 10 मिनट टाइम देखिएगा, कभी भी प्रैक्टिशनर लोगों को भी मैं कह रहा हूँ तो आपको ये उतना कमबरसम नहीं लगेगा जितना ऐसे लगता है. MCH, it is the measurement of average weight of hemoglobin in each RBC. This is very interesting. It is the measurement of average weight of hemoglobin in each RBC. That is MCH. And you can calculate it with the help of this formula. that is MCH equal to hemoglobin, that is gram per dl into 10 to the power 12 per liter. Normal value is 28 to 34 picogram. Now MCH in the same way you can see, and red cell distribution width, it denotes variation in size and distribution of RBC. Mind you, इसलिए RDW हम लोग बराबर कराते हैं. Or it is expressed in two ways, that is red cell distribution width, coefficient of variation, and second is red cell width, that is standard deviation. Now this is the graph you can well appreciate, and if you will feel like having this presentation, I will transfer this presentation on your email and you can go. ऐसे नहीं होगा, इसमें time लगता है थोड़ा. You will have to give time to appreciate all these formulae, and then you can diagnose anemia in a better way. Now RDW values and MCV आप ये देख लीजिए कि RDW high है तो क्या होगा, और देखिए लो MCV है तो आयरन डेफिशिएंसी एनीमिया होगा. नॉर्मल MCV है तो वो नॉर्मल है, बच्चे को कुछ नहीं है. तो इस तरह से आप आगे बढ़ सकते हैं. लेट मी टेल यू अबाउट मेंजर इंडेक्स. दिस इज अ मच टॉक्ड अबाउट इंडेक्स इन this anemia and hematology. In hematology, we usually talk about this Menger index. It is simple calculation that MCV in femtoliter divided by RBC count millions per mucoliter. So you can calculate simply. MCV को RBC count से divide कर दीजिए. बस आपका Menger index. Why Menger index is important? This is the question. If Menger index is less than 13, you can think of thalassemia. And if Menger index is more than 13, you can think of iron deficiency anemia. So it's so simple. Now reticulocyte count, let me tell you that in reticulocyte count, it indicates bone marrow activity and it is done by supravital staining. It is falsely increased in anemia. Reticulocyte count will be increased, in anemia. तो तब तो आप कहिएगा कि इसको reticulocytosis है. No, you will have to have a corrected, reticulocyte count. Or another term for this corrected reticulocyte count is reticulocyte production index. Reticulocyte production index. ये भी simple है. Reticulocyte percent को multiply करिए observed hematocrit divided by normal hematocrit से into 1 by mu. Mu is a fixed number. तो ये आपको corrected मिलेगा, जिससे कि आप differentiate करेंगे कि real reticulocytosis है कि एनीमिया के कारण reticulocytosis हो रहा है. तो that is important. Now low reticulocyte count देखिए, congenital और acquired, aplastic और hypoplastic anemia, pure red cell aplasia. Parvovirus को आजकल underestimate आप मत करिए. Always remember parvovirus, B19 infection and bone marrow infiltration by malignancy and storage disease. High reticulocyte count, hemolysis, hemorrhage, splenic sequestration, all these things. यहाँ peripheral smear की बात होती है. तो let me just give you all a passing reference to all these color, shape, size of RBCs. They are very important. Just a passing reference in brief I will give you in brief. Size आप देख लीजिए. Macrocyte MCV less than 80 femtoliter. अब मैक्रो को 100 से ऊपर मान के चलिए. 2-4 PG को मैं पहचानता हूँ यहाँ बैठे हुए हैं, तो इसलिए इस सबको आपको जानना होगा. N cytosis is different types of RBCs so far as size is concerned. When shape is concerned, you say poikilocytosis. Therefore, you will have to appreciate all these things. Now shape, you can see. Now classification of anemia. You can see WHO का classification है anemia का. Many a times हम लोग को लगता है कि anemia का क्या classification होगा. But आप age wise इसको देख लीजिए कि किस तरह से किस age में anemia को हम लोग on the basis of severity हम लोग classify करते हैं. Now microcytic anemia, आप इसको देखिए कि क्या होगा. Microcytic इसका बहुत सा है. Please go through the books. और उधर देखिए रेटिकुलोसाइट काउंट जो है हाई यदि है, माइक्रोसाइट भी है, और हाई रेटिकुलोसाइट काउंट है तो आपको थैलेसीमिया को याद रखना होगा, हीमोग्लोबिन सी एंड ई को याद रखना होगा. तो दीज आर द थिंग्स. Normocytic anemia, I need not tell you about this. Macrocytic anemia, you can see. ठीक है, what is the scenario? कुछ नहीं है, भारी नहीं है ये, आप थोड़ा सा टाइम देंगे तो आपको पता चल जाएगा क्या कॉजेज है, और हाई है MCV तो क्या है. नो बेड साइड MCV इंटरप्रिटेशन, ये इसको भी आप, दीज आर द डेटा यू शुड रिमेंबर, और डेटा को आप रिमेंबर करेंगे तो सो गुड. अप्रोच टू नॉर्मोसिटिक एनीमिया, ये चार्ट है, और इंडिकेटर्स ऑफ एक्सेलरेटेड इरिथ्रोसाइट डिस्ट्रक्शन और हिमोलिसिस, ये देख लीजिए इसको कि क्या इंडिकेटर्स है. हिमोलिसिस हो रहा है, हाउ विल यू नो, हाउ विल यू नो. तो रेटिकुलोसाइटोसिस, इनडायरेक्ट हाइपरबिलिबिनीमिया, इंक्रीज फीकल एंड यूरिनरी यूरोबाइलोनोजेन, इंक्रीज सीरम लैक्टेट डिहाइड्रो LDH जो है वो आपको इंक्रीज रहेगा. डिक्रीज इन द लेवल ऑफ हेप्टोग्लोबिन, अ प्रोटीन दैट बाइंड्स फ्री हीमोग्लोबिन, डिक्रीज इरिथ्रोसाइट लाइफ स्पैन एंड डिक्रीज ग्लाइकोसिलेटेड हीमोग्लोबिन. तो ये इंडिकेटर्स है आपको हेमोलिसिस का. Now approach to macrocytic anemia, I need not go, you can see because the chart is a big one, and I will request you all to go through the book, give 2 or 3 days on anemia, and you will appreciate the different things. Now difference between IDA and thalassemia, I also don't want to go into the details. You will have to know RBC count, RDW, serum ferritin, TIBC. हम लोग अपने डे टू डे प्रैक्टिस में कराते ही हैं जांच, तो इन चीज़ों को आपको देखना होगा. Now difference between IDA and anemia of chronic disease, इसको देख लीजिए, छोटा है. एनीमिया ऑफ क्रोनिक, ACD इज एनीमिया ऑफ क्रोनिक डिजीज. तो इसमें देखिए सीरम फेरिटिन और इधर आयरन डेफिशिएंसी एनीमिया में डिक्रीज रहेगा, और क्रोनिक जो डिजीज के कारण एनीमिया है दैट विल बी नॉर्मल और इंक्रीज्ड. दिस इज वेरी इंटरेस्टिंग. TIBC का क्या पोजीशन रहेगा? आयरन डेफिशिएंसी में एनीमिया में इंक्रीज रहेगा TIBC, वेयर एज इन केस ऑफ एनीमिया ऑफ क्रोनिक डिजीज डिक्रीज और नॉर्मल. तो दीज थिंग्स यू कैन go through from your book. Approach to macrocytic anemia, this is the flow chart. किताब में दिया हुआ है, आप सबको देख सकते हैं. Clinical difference in megaloblastic and non-megaloblastic anemia. Diet is very important because आपको megaloblastic anemia में you will get the history of vegetarian diet. Number 1. Number 2, हो सकता है goat milk वो पिला रहा हो, बकरी का दूध दे रहा हो जो कि deficient है in folic acid. So you can have this dietary history. A non-megaloblastic it will be normal. History that is mucosal involvement will be more in megaloblastic anemia. You can remember it. But systemic involvement will be more in megaloblastic anemia. Tremors, infant में tremors ज़्यादा मिलेगा आपको megaloblastic में. This is very important. Whereas non-megaloblastic normal. Icterus present रह सकता है in megaloblastic में, non-megaloblastic में normal रहेगा. Now, I have 2 case scenarios, but I don't want to go into the details of the case scenarios. I will take another 5 minutes, sir. Iron deficiency anemia is very common, you know. Therefore, one must be having all informations regarding iron deficiency anemia, like how to diagnose and how to treat and how to investigate. All these things must be known. Menger index, you can see it is more than 13. You see Menger index. Serum iron 2 macro, you know, ferritin is 2 nanogram per ml. You diagnosis is iron deficiency anemia. Treatment, you know, 3 to 6 milligram per kg हम लोग oral iron देते हैं. Or it has been seen that oral iron is equally efficacious as the parenteral iron therapy. Therefore, you don't be, always tempted to give iron preparation in parenteral form if you see severe anemia. Oral anemia will also do the same thing. Therefore, you appreciate therapeutic trial confers diagnosis of iron deficiency anemia. 4 वीक आप देंगे तो आपको माइल्ड एनीमिया में इम्प्रूवमेंट होने लगेगा. Now, treatment, you know, in thalassemia, all of us know what is the treatment. And beta thalassemia, you know about beta thalassemia, alpha thalassemia, and how genes are involved in thalassemia. All these things you should know. Stem cell transplantation is a new thing which postgraduates and we should know about, like definitive treatment. Optimal age is 2 to 10 years. Patient status optimally chelated, and ideal donor, HLA matched sibling donor. ये आपको जानना होगा stem cell transplant. Thank you all for a patient hearing.
Thank you, Dr. B.P. Jaiswal. You have nicely and in lucid way you have described about everything about anemia. It is a very, very common problem, and by your lecture, I think all the clinicians and the practitioners will follow your guidance and the advice. Thank you very much.
Thank you, sir, for your nice words.
Sir, you offered to provide the slides to anyone who gives his mail ID.
Yes.
And I'm very much sure everyone who is sitting in this hall will ask for the slides. They were very informative.
Thank you, Madhu. I will send this preparation PowerPoint on your mail, and you please do the needful, if you feel like so.
Okay, sir. Thank you very much.
Thank you so much, everyone. Now, we are going to move to our next topic. Sick neonate think beyond HIA. This is going to be our next topic. And our speaker is already on stage, Dr. Kian Mishra, sir. And now I'd like to invite our honorable chairpersons to chair the session. Dr. Athar Ansari, who is Professor of Pediatrics at NMCH, and the next chairperson is going to be Dr. Kamocha, who is eminent pediatrician from Darbhanga. I'd like to request both of the chairpersons to kindly be seated so that we can start our next session. Dr. Athar Ansari, I'd like to request you to please join. And then I would also like to request Dr. Kamod Jha. Dr. Kamod Jha. So thank you so much, and I'd like to be requesting the chairpersons to please continue.
Thank you. Speaker is Dr. Ken Mishra, sir. He is Principal, Darbhanga Medical College, Academic Dean of Bihar Health Services, Professor and ex-HOD of Pediatrics, DMCH, Principal Investigator of ICMR, Pneumococcal Pneumonia and Meningitis Project, ex-President Bihar NNF, ex-Secretary IP Darbhanga, undergraduate and postgraduate medical teacher and examiner, guided many dozens of theses, publication in national and international journals, organizing chairperson of 32 Bihar PEDICON Darbhanga. Thank you, sir.
Sir, please start the session, sir. Thank you.
Thank you, Chairperson. Warm welcome to you in this scientific congress, although a few persons are left. The audience is very poor, but I have to do the job. I know you all are wise, so you have left the hall than me, but I am standing before you to assure you that the eyes cannot see what the mind does not know. इधर बढ़ते रहे हैं तो वही ये तो आ गया यही बोला था फिर ये तो हो गया ठीक अच्छा चलो नेक्स्ट को हाँ हाँ तो यही ना है I stand before you to air encephalopathy of the newborn, which we diagnose HIE, but this is time to think beyond HIE. We have learned many things about HIE. We have worked hard by doing neonatal resuscitation program, NSK, and advanced neonatal resuscitation program. And we have reduced the mortality from HIE now. I want to urge you to find out the hidden cause of the neonatal mortality. Neonatal mortality remains a significant concern in India. HIE encephalopathy and sepsis have traditionally been leading cause of neonatal mortality. Now, preterm birth and the low birth weight are emerging as the leading cause of neonatal mortality as our health facilities are improving. Preterm infants are increased vulnerability to metabolic issues, cardiac disease, and genetic problems. See this picture and think about this. Appearance of appearance of a screening, also known as newborn From this picture, appearance of Cushing's in a neonate, that is rounded moon faces with plethora and facial hirsutism are present. This is usually accompanied by the presence of typical capholate efforts elsewhere in the examination. Think for this. Certain metabolic and endocrine disorders may present with physical abnormalities. For instance, an enlarged liver or a spleen in a newborn might indicate a metabolic storage disorder such as Gaucher's disease. A pediatrician's ability to suspect metabolic and endocrine disease at birth relies on a combination of clinical observation, thorough medical history, family history, and in some cases, a pediatrician's ability to suspect metabolic and endocrine disease at birth relies on a combination of clinical observation, thorough medical history, family history, and in some cases, advanced diagnostic testing. Early detection allows prompt intervention and management, improving outcome for the newborn. Regular communication with a specialist and multidisciplinary approach are essential for comprehensive care. Now the neonatal screening. These are the 4 headings. Timing of the screening, what are the mandatory testing is essential, and the screen disorders, blood sample collection from which site, and follow-up for confirmation. Neonatal screening, also known as newborn screening, is a public health program designed to identify certain medical genetics and congenital disorders in the newborn before they exhibit symptoms. The goal is to detect these conditions early, allowing for prompt intervention and treatment to prevent or minimize long-term health issues. Neonatal screening programs contribute significantly to public health and preventing severe disabilities and improving the quality of life for affected individuals. The specific disorders included in the neonatal screening panels are cystic fibrosis, G6PD deficiency, thyroid screening, biotin deficiencies. These all are the phenylketonuria, all are the essential newborn screening. Prenatal, utilize advanced imaging techniques such as fetal echocardiography during the prenatal care to identify any potential ductus-dependent lesions. Now at the clinical assessment at birth, conduct a thorough clinical assessment immediately after birth, paying close attention to signs of cyanosis, respiratory distress, and abnormal heart sounds. Diagnostic imaging. Employ diagnostic imaging modalities such as echocardiography to confirm the diagnosis and assess the anatomy, function of the heart. Echocardiography is particularly valuable in identifying the specific ductal dependent lesions and guiding treatment decisions. Now the oxygen saturation monitoring. Continuous monitoring of the oxygen saturation levels can aid in the early detection of ductus-dependent lesions, especially in asymptomatic cases. Pulse oximetry. Monitoring oxygen saturation helps in early identification of hypoxemia, a critical factor in the neonatal morbidity. Timely intervention can prevent complications associated with oxygen deprivation. pulse oximetry. Then early detection of hypoxemia. Monitoring oxygen saturation helps in early identification of hypoxemia, a clinical factor in neonatal mortality. Timely intervention can prevent these. Acid-base balance. ABG analysis provides information about the baby's acid-base balance, indicating whether the blood is too acidic or too alkaline. It also measures oxygen and carbon dioxide levels. What are the significance of ABG? Particularly useful in assessing respiratory distress by evaluating the baby's ability to exchange oxygen and carbon dioxide in the lungs. Assessment of ventilatory status in neonates with respiratory distress, ABG analysis helps in determining the effectiveness of ventilation and the need for adjustment in the respiratory support. Thank you. Thus, the conclusion is this: we have to think not only HIE, but when the newborn comes to in our clinic or in outdoor or indoor, in emergency, we have to think other than HIE also. Thank you.
Thank you, sir, for this nice deliberation.
Thank you, sir.
Thank you so much to the speakers. I request all of you to please collect your memento from the rear side of this hall. And then let's begin our next topic, which is death, the leveler. And it is going to be the second last topic of this beautiful day. So I'd like to request all the chairpersons to please join. First of all, I'd like to invite Dr. Kumar Anand, an eminent pediatrician from Darbhanga, director of Sony Childcare Center. He has an experience of 10 years in the field of pediatrics. And then Dr. Pramod Kumar, who did his SR-ship from CNBC Delhi, and he is also the director of Max Child Health Clinic. And then I'd also like to request to join Dr. Dheeraj, who is practicing pediatrician of Darbhanga, and also Dr. Aruna, practicing pediatrician of Darbhanga. So I'd like to request Dr. Kumar Anand, Dr. Pramod Kumar, then Dr. Dheeraj and Dr. Aruna. Dr. Dheeraj and Dr. Aruna. Okay, let's start. Anyways, now it is the time to invite our next speaker, Dr. Om Prakash, to give a presentation on death, the leveler. This is going to be our next topic. Dr. Om Prakash, you are requested to please come on the stage and to start your presentation. Thank you so much. And now I request the Honorable Board of Chairpersons, any of you, kindly give us a brief introduction.
सर, आपकी मैसेज आप मैसेज दें पेडिकॉन को, मैं आपको स्पीकर पर ले रहा हूं. बोले सर. डॉक्टर रुपेश किंडेवाडेकर, प्रेसिडेंट आईएपी. हाँ बोले सर. वीडियो कॉल पर ले लेंगे, ट्रांसफर कर देंगे आप. हाँ. इसको ले सकते हैं आप वीडियो कॉल को, वहाँ पे नहीं कर सकते हैं सर? हेलो, कोई एक आदमी मुझको मदद करेंगे इस मोबाइल पर? डॉक्टर उपेंद्र किंजे वाडेकर हैं, अनिल, आप उनसे बात करके कनेक्ट करके बोलें, मैं उनको यहाँ पर प्रोजेक्शन दे दूंगा कैसे भी। आपका मेरा व्हाट्सएप है, व्हाट्सएप आप चला सकेंगे ना इस पर? आपको व्हाट्सएप उस पर देखिए, बात करिए इनसे। वो वैलिडिटी चल रही है आपका मैसेज बाकी पेडिशन के लिए। आवाज़ आ गई, आवाज़ आ गई, देखिए वहाँ जाके फिर से कर लीजिए। माइक हमको एक माइक दे दीजिए, माइक सुनिए ना। I am very happy that I am going to talk in front of my sister, Dr. Piyali Bhattacharya, and my friend Neelam Mohan. So I am the last person today, and I do not take more time. I started as chairperson of this conference, but I am finishing with as a speaker. So that the leveler. मैडम थोड़ी मेरी सुन लें। मैं आनंद की एक बहुत मशहूर लाइन से शुरू कर रहा हूँ, जहाँ एक टेप चल रहा था और उसमें बज रहा था, मौत तू एक कविता है, मुझे इस कविता का वादा है, मिलेगी मुझको डूबती नब्जों में जब दर्द को नींद आने लगे, जर्द सा चेहरा लिए जब चांद फक तक पहुँचे, दिन अभी पानी में हो रात किनारे के करीब, न अंधेरा न उजाला न रात न दिन। Before delivering into the interstage of our discussion today, I would like to take a moment to acknowledge profoundly the sensitive nature of this topic we are about to explore. Coping with pediatric deaths is an emotional and complex journey for the families, caregivers, healthcare providers, and all the persons. So what is the death? There are two things. Clinical criteria for the death is irreversible cessation of the heart function, cessation of respiratory function, and neurological criteria. This is made for the organ donation. Here, no detection of the brain activity. So, there are legal and ethical considerations. I am not going to detail today because there is. So, first of all, think, is it preventable? No, death is not. It is a final truth. But in pediatric cases, we may learn how to diagnose when the patient is in distress. And we can do the training which we have done previous workshop. That is IAP, ALS, BLS, advanced NRP, basic NRP. All these can do something to delay or prevent the death. So we are not doing this thing rightly. Every death have a procedure of medical inquiry in case of death. And in the context of the determining the cause of death, the terms primary and secondary refers to the main contributing factor and that lead to the person device. So the primary cause of death is often referred as the underlying cause. He is the fundamental factor that initiate the chain of event leading to death.